Hello. A very good evening to all of you. And first of all, my sincere apologies to all of you for the delay in the starting of the session. That was due to some emergency which came up suddenly. So the class was supposed to start at 4 o'clock, but it is almost 5:40 p.m. Right. Anyways, today what we are going to talk about, we'll be discussing. Just give me a moment. Let me just check whether things are right or wrong. Right. So I hope things are going good. Great. Right, beta. So in surgery, we are at page number 118, right? And now, from today, we are starting totally fresh. That is the surgical problems which can come in adults. And before we start, let us just try to take a look at what all surgical problems in adults you are going to deal with in your clinical practice from February 2023. If we take a look in a sequence from top to bottom, beta, if we start from top, then here, that is just the starting point of the esophagus. In the pharynx area, there is Zenkus diverticulum, which can cause difficulty in swallowing. We'll be talking about other causes of dysphagia, and we can understand that dysphagia would be simply difficulty in swallowing. So that would be something which would be related to problems in the pharynx or maybe the esophagus, right? So in dysphagia, we not only talk about Zenkus, but we also talk about achalasia cardia. Then there are certain other common conditions which can cause dysphagia, like diffuse esophageal spasm, nutcracker esophagus, Schatzki's ring. These are the problems which can cause difficulty in swallowing. So we'll talk about those problems one by one. Then here in the thorax, we'll also be talking about chest pain. Now, chest pain is something, chest pain is something what we commonly see in heart attack type of stories, but here we'll be focusing on the surgical causes of chest pain. Like a common cause what we can come across is gastroesophageal reflux disease. Sometimes what happens, the stomach acid may reflux up into the esophagus, and that causes heartburn or chest pain type of story here. Various other causes like hiatus hernia, which can be a complication of gastroesophageal reflux disease. Bohr-Havi syndrome, which is rupture of the esophagus. Sometimes in alcoholics, there is high pressure inside the stomach and the stomach contract forcefully, profuse vomiting, rupture of esophagus, and that can lead to chest pain. Once we are done with this thoracic part, then we'll come into the abdomen, and in the abdomen we'll be going in a sequence starting from the epigastric story, then into the right hypochondrium, then into the lumbar or the flank region, then into the iliac fossas, the right iliac fossa, the left iliac fossa, then the hypogastrium. Then we'll be talking something related to the groin area like inguinal hernias. Then we'll be talking something in the penile area, something in the scrotal area like testicular torsion, hydrocele and varicocele type of stories. And then we'll be turning the patient back and we'll be talking about rectum and anal canal stories. So if we take a look, in the epigastrium, mainly we'll be focusing on the stories of gastritis and peptic ulcer, because this is the area belongs to stomach and duodenum. So any patient coming to you with epigastric pain, or 17th of December, any question which is coming with epigastric pain in an adult, you should start thinking these differential diagnoses may be a case of gastritis or peptic ulcer, sometimes GERD, pancreatitis and cholecystitis, pancreas is lying in this part of the abdomen. This is the retroperitoneal area, and gallbladder is lying in this part. That is inflammation of the gallbladder is cholecystitis. So sometimes this cholecystitis can also present with epigastric pain. Then after talking about the stomach duodenal stories mainly, we'll move to the right hypochondrium, which belongs to the liver and gallbladder, and the bread and butter of a surgeon, gallbladder stones. So here we'll be focusing mainly on the gallbladder stones. We'll also be seeing that how the gallstones can cause complications, like they can slip into the common bile duct, choledocholithiasis leading to cholangitis and all those stuff. Then we'll be talking about the other problems which this gallstone can cause, like pancreatitis. We'll be talking something about liver abscesses and sigmoid volvulus. Then we'll be talking about the lumbar region, and this region belongs to the kidneys. And in adults, common surgical problem related to kidney would be the stones in the kidney, ureter, bladder area. Also, tuberculosis of the urinary tract, like renal TB, bladder TB, we'll be talking about those stories also in the lumbar region. Then we will move down into the right iliac fossa, where we know that the most common operation done in emergency by a general surgeon is appendicectomy. So this right iliac fossa will be focusing on acute appendicitis. Apart from this, we come across inflammatory bowel diseases like Crohn's and ulcerative colitis. In the left iliac fossa, we focus on the diverticulosis of colon. Then we'll move into the hypogastric story. Here we'll be talking about urinary bladder traumas, trauma to the urethra also, and we'll also be talking about a very common problem in elderly males, that is benign prostatic hyperplasia. Once we are done with this area, then we'll be talking about the inguinal hernia stories. Then we'll be talking about the penile stories like phimosis or Peyronie's or priapism type of diseases. In the scrotum, as we were talking about, testicular torsion, varicocele, hydrocele, and then we'll turn this person upside down and we talk about the rectum anal canal stories like hemorrhoids, anorectal abscesses, fistula in ano, anal fissure, and pilonidal sinus. So this is a complete indexing what we want to talk about in adult surgical problems, and we know that this adult surgical problem is going to be the most important chapter as far as 17th of December is concerned, because majority of the questions, approximately 30 to 40% of surgery questions, will be coming from this adult surgical problem story, right? Fine. So let's take a look one by one, and gradually we'll keep moving down. So let us first start with the story of dysphagia. Now, what this dysphagia will be all about, if we try to take a look and try to understand with some images. Now herein what we can understand better, that whenever we are eating something, dysphagia simply means difficulty in swallowing. We are eating from the mouth area, suppose, and now suppose you are taking some rasgulla or something. Now that rasgulla would be going into the pharynx area. Just give me a moment, beta. But I'm really sorry that I'll have to take excuse for approximately half an hour. So what we are going to do is we'll try to resume this session at 6:30 p.m. But I'm really sorry. There's the emergency which I was stuck in. That is suddenly I have received a call again. So I think I'll join you at 6:30 p.m. I sincerely apologize for the unwanted delay in today's session. I hope you are able to understand my current situation, and hopefully we'll resume at 6:30 p.m. The link will continue like this. I'm not breaking the link. It will remain just like that. Okay? But Indian Standard Time, I'll try to be back by 6:30 p.m. Thank you for your understanding and patience. Thank you very much. Hello, hello. Right, beta. So now the things are sorted, and hopefully we'll be able to continue the class nicely now. Uh, right, beta. So let's come back and let us start totally fresh. That we want to talk about the stories of dysphagia. And if we have to talk about the stories of dysphagia, beta, then if we just try to understand that God has given us the mouth to eat, and then whatever we eat, that comes into the pharynx, and from the pharynx it is going into the esophagus, and then it will be going into the stomach. Now, beta, if we are saying dysphagia, difficulty in swallowing, that means if you just try to create a traffic jam situation either in the pharynx or in the esophagus, अगर बेटा हम किसी के pharynx या esophagus को दबा देंगे तो जो भी वो खाना खा रहा है वो अच्छे से नहीं जाएगा ना नीचे. When you are pressing the pharynx or the esophagus, then whatever food the patient is eating, that will not be going nicely inside, है ना. So in these situations, beta, the patient have difficulty in swallowing. Now we'll just try to understand. We can name the different pathologies differently, but conceptually what is needed to understand is that let us imagine a situation when you are pressing somebody's esophagus, right? Now whatever food is coming down, that food will not go down into the stomach, so that food will be staying here in this area. The pressure in this area will increase. This food is causing somewhat like a traffic jam situation, right? So the pressure in this upper part will increase and there will be chance of regurgitation. And when the story is regurgitating, beta, there is always a risk. As you can see, the trachea is lying anteriorly. So if suppose the ras of the rasgulla or the liquid of the rasgulla that goes back into the mouth, there is a risk of aspiration, and this aspiration can lead to pulmonary complications. Right? So this would be the presentation of these dysphagia type of stories. Now, what can be the different stories? Here we are talking about a Zenker's diverticula. Look at me on the screen, beta. Look at me on the screen. Very simple to understand. If suppose I say that here is the pharynx. Suppose, beta, this is the pharynx area. Right? And below this, I say this is the esophagus area. At the starting point of esophagus, beta, God has given a constriction to all of us, and that is the narrowest part of entire GIT. This what you are seeing, the pinky story, this is the cricopharyngeal sphincter. Just imagine, beta, if the tone of the cricopharyngeal sphincter is tight, if this area becomes tight, it will cause a traffic jam situation. So pressure above will increase. The proximal people will dilate. And when the pressure above will increase, this high pressure will try to force the mucosa of the pharynx to protrude outwards. And beta, in this area, God has given a natural weakness. And that natural weakness is actually the Killian's dehiscence. There is a triangular area, beta. This is the triangular area, a Killian's triangle or a Killian's dehiscence, which is in the inferior constrictor muscle between the fibers of thyropharyngeus and cricopharyngeus. So what can happen whenever the pressure in this area will increase? If the pressure in this area increases, then this might force the mucosa of this area. Suppose I say that mucosa of this area is green color like this. Now, if the pressure inside increases, what can happen? This green area may start protruding out through the Killian's dehiscence. And this is what we call as a diverticula. So, gradually what will happen? This pharyngeal wall, the posterior pharyngeal wall, will try to outpouch like this. And this will result in the Zenker's diverticulum. Right? Now the problem, what can happen if the diverticula has occurred, what can happen here beta? Just imagine that this patient, now this patient is taking the food, right? This is the trachea what you're seeing. Here, this is the esophagus and this will be the pharynx area. What is happening? When a diverticula has occurred, can you see this laddu type of swelling here? This is what is a diverticula. When the patient takes some food, suppose the patient is taking a rasgulla, right? Now that rasgulla will come into this diverticula, and this food in the diverticula will put pressure on the esophagus. Can you see how the esophagus is compressed? If the esophagus is compressed beta, then patient will not be able to swallow further foods, difficulty in swallowing, dysphagia. That will be the characteristic presentation of Zenker's diverticulum. Also beta, we know that if suppose there is a outpouching from the organ which does not contain all the layers of the organ, then we call such diverticulas as false diverticulas, right? So if we take a look what all is written in our workbook. Zenker's diverticulum. Zenker's diverticula, this is a also called as beta pharyngeal pouch. ये भी ध्यान रखना, nowadays your examiners are becoming very smart. They may not use the term Zenker's diverticula, they may just use pharyngeal pouch. The other name of this problem is cricopharyngeal achalasia, right? What do we call this? Zenker's pharyngeal pouch and cricopharyngeal achalasia. There is outpouching of posterior pharyngeal wall posteriorly above the cricopharyngeal sphincter. So the CPS beta, this is cricopharyngeal sphincter. Cricopharyngeal sphincter through the Killian's dehiscence. Killian's dehiscence. And this Killian's dehiscence beta, this is found in inferior constrictor muscle. Your anatomy faculties, your ENT faculties, they also will be focusing on this inferior constrictor muscle. This is basically the fibers of thyropharyngeus and cricopharyngeus muscle. Fibers of thyropharyngeus and cricopharyngeus muscle. So we are just trying to understand. It is a very simple story beta. Whenever the tone of the cricopharyngeal sphincter becomes tight, the proximal people will dilate, pressure in the pharynx will increase, and high pressure in the pharynx will force the posterior wall of the pharynx to protrude posteriorly. That is, mucosa of the pharynx will protrude posteriorly, right? And posteriorly, in your pharynx also beta, you have got a natural weakness in the form of Killian's dehiscence, and this is in the inferior constrictor muscle between the fibers of thyropharyngeus and cricopharyngeus. These Zenker's diverticula, these are acquired diverticulas. They are false diverticulas because they do not contain all the layers. Any diverticula which contain all the layers of the organ is called as true diverticula. Which layers would be present here? It is usually the mucosa and maybe the superficial submucosa. Maybe the superficial submucosa. That will be seen in this diverticula. Acha beta, we also know the chances of this diverticula will be more common in children, adults और elderly. किसमें ज़्यादा चांस होंगे बेटा इस एक्वायर्ड डाइवर्टिकुला के? जैसे जैसे हमारी उम्र बढ़ती है, दीवारें कमज़ोर होती हैं, इमारतें कमज़ोर होती हैं. So as we are growing older, the tissues are becoming weaker and weaker. So the chances of this diverticula will be more in elderly people, right? 50% of the times, these Zenkus diverticula can be associated with cervical webs. Now, the question which comes to my mind, ki bhaiya, suppose this is the pharynx, and here we are seeing that this is the outpouching from the pharynx, and here, suppose I say that this is the esophagus. This blue color is the esophagus. Now, in between the two, we know there is a cricopharyngeal sphincter. Whenever the tone of the sphincter is tight, the pressure above will increase and this will force the Zenkus. Sometimes, beta, in Zenkus diverticular patient, we have found that God has given some webs also in this area. Cervical web, that part of the esophagus which is in the neck, that is called as cervical esophagus. I repeat, beta, dhyan se suniye. That part of the esophagus which lie in your neck, that is called as the cervical part of esophagus. And in 50% of patients of Zenkus diverticulum, we have found that God has given some webs in this area. Now, web is just like the spider web. जैसे मकड़ी का जाला होता है ना बेटा. Now that मकड़ी का जाला, that spider web, right? If somebody is having that spider web here, that can act as a resistance. And that will also hinder the story going down, so the pressure above will increase. That is how we have found that in 50% of patients of Zenkus, we can find these cervical webs. Now comes, beta, how these patients will present to us. Most common clinical feature. Beta, this CF what we are using, this means clinical feature. That means how the patient presents to us. So most commonly, what is going to happen? Look at the screen once, beta. If suppose the diverticula comes like this, now can you appreciate, beta, this diverticula? If suppose somebody is taking food, suppose rasgulla. Now rasgulla is going here, and this rasgulla would be coming into the diverticula, and this would be pressing the esophagus from outside. There will be compression of the esophagus now, so there will be difficulty in swallowing. That is called as dysphagia. Dysphagia, that is simply difficulty in swallowing. The pressure above is high, so the chances of this rasgulla going up are more. Regurgitation. This can lead to aspiration and pulmonary complications. Like if the rasgulla goes into the trachea, into the lungs. So just imagine rasgulla in the lungs. That will create some complications, infections in the lung. So abscesses can form in the lung, right? Also, beta, if suppose the rasgulla stays here for a long period of time. Now, if the rasgulla stays here for a long period of time, then this rasgulla, this will be invaded by the bacteria. Bacterial infection that will lead to foul smelling breath. Simple, beta, if you keep the food somewhere for 2 days, 3 days, it starts smelling ना, it starts bad smelling. कहीं भी बेटा अपन 2-3 दिन का खाना अगर पड़ा होता है तो बदबू मारने लगता है ना वो. The same story is seen in Zenkus. Any traffic jam situation, look at me, beta, any traffic jam situation in the esophagus where the food is not going down properly, the food is staying up. If the food remains there for some time, then there will be bad smell. And since this area is very close to the mouth, the patient will have bad smell in the breath. हर सांस में बदबू होगी, right? That is what we call as halitosis. Okay, so this is foul smelling breath. How these patients can present to you, beta? They can present with a midline neck swelling. Apart from this dysphagia, what you can do is, you can elicit one sign which we call as Boyce sign. Now, what is Boyce sign, beta? Just imagine that a patient is presenting with a swelling in the posterior part of neck. And this swelling, ये जो diverticula है बेटा, this diverticula will be having the air also, क्योंकि आप मुंह से जो हवा लेते हैं, that air would be going here. The liquid or the salivary juices would also be going here. The food will also be here. Whenever you try to press this swelling, अगर यहाँ से गर्दन पे पीछे से दबाने की कोशिश करते हैं, if you try to press it, all the swellings in the body or everything in the body wherever there is mixing of air and water. As soon as you try to squeeze the swelling, the air will get mixed with water and this produces a characteristic gurgling sound. For example, if I just try to show you here, just look at me beta, if I try to gurgle, what is this? This is mixing of air with water, gurgling sound. So any swelling in the body which has got both air and water inside, that is going to produce this characteristic sound, and this is what we call as Boy's sign. Remember this concept beta, February 23. NB would be giving you the license in December, right? So February 23, when you're working in the hospital, you may come across this situation in inguinal hernias. Just imagine inguinal hernia. That means, suppose, imagine that intestines have come through the inguinal canal into somebody's scrotum. Patient comes to you with a swelling in the scrotum, and by chance, suppose the intestines are going into the scrotum. Now, if you try to squeeze somebody's scrotum, if there are intestines inside, in the intestine, there will be air, there will be liquid. So mixing of air and water will produce this characteristic sound, gurgling sound. Here in Zenkus diverticulum, we call it as Boy's sign. In ENT classes, there is a condition called as laryngocele. There your ENT sir will be telling you about a Bryce sign. Bryce sign. Okay, coming back beta. So Boy's sign is what? It's a gurgling sound heard on reducing the swelling. You can just make a note somewhere on the side. Bryce sign, Bryce sign. This is seen in laryngocele. Laryngocele. Okay. To diagnose these Zenkus diverticula beta, if the patient is complaining of dysphagia, you can just ask the patient to swallow the barium. Now, when you ask the patient to swallow the barium, now suppose the patient is swallowing the barium like this, and you are taking the pictures. So the contrast is going inside. If the story would have been normal, you would have seen the contrast flowing normally like this. For example, in this particular case, the contrast would have been flowing somewhat like this. I repeat beta. Now just try to see. If everything would have been normal, the story would have been something like this. The contrast would be going like this. But here, the problem is there is outpouching. So if there is outpouching, can you appreciate that how you can see a diverticula on barium swallow? So this is what is a Zenkus diverticula on barium swallow. This is the investigation of choice for Zenkus diverticulum. ठीक है बेटा? This can be asked as a image based MCQ. एक बार और अच्छे से ध्यान से देख लो बेटा. This can be asked as a image based MCQ. Let me remove myself also. Right. Now this is what is a Zenkus diverticula. पहचान लोगे बेटा इसको? Can you see this outpouching here nicely? Wonderful. Right. चलिए. So investigation of choice is a barium swallow. Now depending on what is the size of this diverticula, we have to treat these diverticulas like if it is a chota sa diverticula, middle sized diverticula or a large diverticula. If the diverticula is less than 2 centimeters beta, we simply do a cricopharyngeal myotomy. Cricopharyngeal myotomy. अभी ये CP क्या है बेटा? This is cricopharyngeal. Cricopharyngeal. What does this mean? That if suppose there is a small diverticula, what we can do is we can simply make a cut on the suppose I say beta, this is the story. There is a small diverticula coming out from the pharynx. Now in these cases, if this is a small diverticula, you can just make a longitudinal cut on the cricopharyngeal sphincter. By making this cut here beta, you will relax this area. If this area is relaxed, the pressure above will decrease and the diverticula can regress on its own. So for a small diverticula, we are just making a cut on the cricopharyngeal sphincter. That is a cricopharyngeal myotomy. If the diverticula is little big in size, then for these diverticulas, we have to fix these diverticulas. We just push them back and then suture in the wall of the pharynx here. And that is fixing of the diverticula, which we call as diverticulopexy. Fixing of anything in surgery is called as pexy. Like in pediatric surgery, undescended testis, you bring the testis down to the bottom of the scrotum and fix the testis to the bottom of the scrotum. So fixing of testis is called as orchidopexy. Here fixing of the diverticula is called as diverticulopexy, right? Diverticulopexy. If suppose there is a very large diverticula, say more than 4 centimeter in size, then we do a MCQ operation here. That is called as Dolman's operation beta. Dolman's operation. This is a diverticulostomy. Diverticuloesophagostomy. For this operation, we use linear stapler. Linear staplers are used beta. Linear stapler is used for diverticuloesophagostomy. Let us see the picture beta. What do we mean by this Dolman's operation? This has been asked in our exams. Dolman's operation is done for. The answer is Zenker's diverticula. If we take a look what is actually Zenker's diverticula, what is actually Dolman's operation beta? So this is what we are seeing is the Dolman's operation. Abhi dhyan se dekhna beta, be careful here. This instrument what you are seeing beta, this is actually a linear stapler. It is just like the stationary stapler now, but the difference between a surgical stapler and a stationary stapler has got pins. So whenever you fire the stationary stapler, it pins, it sutures. And the surgical stapler, which is used inside the body, that has got a knife as well as pins. So surgical stapler, which is used inside the body, has cuts and sutures. Kaatta bhi hai, jodta bhi hai. What you are doing here beta in a large Zenker's diverticula, since you will not be able to remove this diverticula, what we can do, we just divide the septum which is there between the diverticula and the esophagus. This is the septum between the esophagus and the diverticula. So what you are doing here, you are just trying to pass this here as well as here. And now you just press the handle. As soon as you press the handle, whatever is there in between, that will be cut. And whatever is left will be sutured, right? So as soon as you press this, what happens? The septum is cut and the outcome will be somewhat like this. This story. Now what is the advantage beta? When the patient will take the rasgulla, he is taking the rasgulla from here. The rasgulla will be going down here. Earlier what used to happen, the rasgulla used to stay here in the diverticula. But now if you have removed the septum, the rasgulla will not be staying here, but the rasgulla will be going down. So if there is no food which is staying in this area, this is not going to put pressure on the esophagus. and the patient will not have dysphagia. So we are just dividing the septum between the diverticula and the esophagus. That is the diverticuloesophagostomy. This what you are seeing on the screen, beta, this is the Dolman's operation. This is the Dolman's operation, right? Okay. So let us just have a quick recap of Zenkus, beta. Zenkus diverticula, also called as pharyngeal pouch or cricopharyngeal ecclesia. This is outpouching of the posterior wall of the pharynx, posteriorly above the cricopharyngeal sphincter through the Killian's triangle, where there is inferior constrictor muscle having fibers of thyropharyngeus and cricopharyngeus. This is the acquired diverticula. False diverticula, as it does not contain all the layers, usually contains only the mucosa and the superficial submucosa. This is more commonly seen in elderly people. 50% of the time we have seen cervical webs associated with Zenkus. Commonly the patient presents with dysphagia. There may be regurgitation, which can lead to aspiration and pulmonary complications. There can be halitosis. Patient presenting with midline neck swelling. When you are doing the examination and try to squeeze the swelling, there will be mixing of air and water, which gives a gurgling sound, which we call as Boyer's sign. The common complication is a pulmonary abscess. Investigation of choice to see these diverticulas is a barium swallow. In the treatment, if it's a small diverticula, you are doing a cricopharyngeal myotomy, 2 to 4 centimeter diverticula, diverticulopexy, and more than 4 centimeter diverticula, Dolman's operation, diverticuloesophagostomy, where we use a linear stapler, divide the septum between the diverticula and the esophagus so that the food does not stay inside the diverticula and it does not press the esophagus, so there is no dysphagia after this operation. Right, wonderful. Another story of dysphagia, that is achalasia cardia. Now here in beta, in pediatric surgery, there is a condition called as Hirschsprung disease or congenital megacolon or congenital aganglionosis. This achalasia cardia resembles that condition. Suppose beta, this is the esophagus and the stomach, what we are seeing here. We know that in GIT, we have got a muscle plexus. There are two plexuses, nerve plexuses basically. One is a submucosal plexus, that is the Meissner's plexus. Another is a motor plexus, that is the Orbeck plexus or Mayentrick plexus, which is in the muscle. And this Orbeck plexus is responsible for movements, motor, muscle, right? So muscular movements. That is how the food actually goes down. But sometimes what can happen, beta G, if suppose this is the muscle layer and we know normally there are ganglion cells, and these ganglion cells are responsible for peristaltic movements. But by chance, if the God has not given ganglion cells here, then the muscle movement will not be there. How will the food go down? So the food will not be going down. Though absence of esophageal peristalsis is considered as pathognomic of achalasia cardia, but here another important thing to know in this, in achalasia cardia, we find that there is selective damage to the inhibitory neurons of the lower esophageal sphincter. One was a cricopharyngeal sphincter beta at the top of the esophagus, ek to yahan tha. Another sphincter is the lower esophageal sphincter. So there is a upper esophageal sphincter, there's a lower esophageal sphincter, this is an anatomical sphincter, this is the physiological sphincter. In achalasia cardia, look at me on the screen. In achalasia cardia, there is selective damage to this lower esophageal sphincter, so that this sphincter is not able to relax. It remains contracted. Now, if it remains contracted, beta, what will happen? This area, the esophagus supposes like this, and now the lower esophageal sphincter has contracted. So this area will become somewhat like this. That means there is a traffic jam situation, plus there is absence of peristalsis. So the food will not be able to go down. This is what is difficulty in swallowing, dysphagia, right? There can be primary eclasia, there can be secondary eclasia. Primary when the exact cause is not known, and secondary when it is associated with some diseases. Like beta, in general surgery, in vascular surgery, there is a condition called as Raynaud's disease. Raynaud's, commonly seen in young females. This is spasm of the arterioles on cold exposure. Primary Raynaud's, secondary Raynaud's. Primary when the exact cause is not known. Secondary when it is associated with some diseases like SLE, scleroderma, rheumatoid arthritis, thoracic outlet syndrome, cervical rib type of stories. Here in ecclesia cardia beta, primary when the exact cause is not known, and secondary when it is due to some diseases, like there is a disease called as Chagas disease that is caused by a parasite Trypanosoma cruzi. Diabetes. In diabetes beta, we know there is a angiopathy and there is a neuropathy. So in neuropathy beta, there is neural weakness, and because of the weakness of the nerves, the strength of the muscle will decrease, right? So the peristalsis will not be proper. Or sometimes if suppose there is a cancer sitting inside the esophagus, that will also not allow the food to go down, right? This is secondary eclasia. Sometimes beta, we can find traffic jam situations in the esophagus, not because of a problem in the esophagus, but because of problem outside the esophagus. For example, if I say that this patient is developing a tumor in the stomach, if there is a cancer in the stomach taking place, जैसे जैसे कैंसर बढ़ता जाएगा वैसे वैसे ये ईसोफेगस को दबाता जाएगा. As the cancer is increasing, it will start putting pressure on the esophagus, because of which there will be a traffic jam situation in the esophagus and the patient will present with dysphagia, right? This is not a problem of the esophagus, but this is a problem outside the esophagus. So this is called as pseudoeclasia. Pseudo means false. Not a problem of the esophagus, but a problem outside the esophagus. Same way beta J, if suppose I say that there is a tumor growing in the mediastinum, there is a tumor in the thorax, and when this tumor enlarges, then this tumor may also start compressing the esophagus from outside. Then also the patient will have dysphagia. So this is also a type of pseudoeclasia. So beta एक बार करते हैं. What is primary? What is secondary? Examples of secondary: Chagas disease, diabetes, cancer inside the esophagus. What is pseudoeclasia? Examples of pseudoeclasia: maybe tumors of the stomach, maybe tumors of the mediastinum, right? Now let's see what all is written here. So ecclesia cardia beta, this is a story where there is failure of relaxation of lower esophageal sphincter. This is lower esophageal sphincter. This is due to D/T का मतलब क्या है बेटा? Due to absence of ganglion cells in the Orbeck plexus in the esophagus. Esophageal peristalsis is absent. Esophageal peristalsis is absent. And this is what is pathognomic of ecclesia cardia. Simple, we can divide this ecclesia into primary ecclesia, secondary ecclesia, and pseudo is actually considered a type of secondary ecclesia only. तो primary में क्या होता है बेटा? Primary में the exact cause is not known, and secondary is secondary to some diseases like Chagas, diabetes, even scleroderma, or even cancer in the esophagus. अच्छा बेटा, scleroderma जो होती है ना, scleroderma, that is a condition where there is increased collagen deposition in the tissues. So the tissues become thicker and thicker. Just imagine the esophagus. If there is more collagen deposition in the esophagus, the wall of the esophagus will become thicker and thicker. The lumen of the esophagus will narrow, and that will cause dysphagia, right? Pseudoachalasia, this is because of tumors around the esophagus, like mediastinal tumors, tumors of cardia of stomach. ठीक है ना बेटा, बात समझ आ रही है ना बेटा? Tumors of cardia of stomach. Pseudo मतलब क्या? False. That means the problem is not in the esophagus, but there is a problem around the esophagus which is causing compression of the esophagus, whether it is mediastinal or tumors of cardia of the stomach, right? Now let us see beta what is going to be the problem actually in achalasia cardia. So if we try to understand the story, suppose beta this is the esophagus normally, and suppose here is the stomach, right? अभी क्या हो रहा है यहाँ पे? As we saw, there is a traffic jam situation in this particular area. This is the traffic jam situation, or I'll make it something like this. Something like this. That means, actually speaking, or I'll draw it here. This was the normal story, but in achalasia cardia, what has happened? The story has become something like this. There is narrowing of the lower esophageal sphincter, and because of narrowing of the lower esophageal sphincter, this is creating a traffic jam type of situation. Acha beta, if there is a traffic jam here, then what will happen to the proximal people? The proximal people will dilate. So what is going to happen to the proximal esophagus? It is going to dilate. That means the proximal esophagus will become somewhat like this, right? This is the dilatation what you are seeing proximally. And here would be the esophagus, something like this. Now we can make out beta that yes, there is a traffic jam in this part of the esophagus, right? Now what will happen to the problem? When the patient is trying to eat, suppose the patient is trying to take the rasgulla. Now the problem in this rasgulla would be when the rasgulla is coming here, then rasgulla will face a problem in going down. And to our surprise beta, this is actually a problem of the muscle. Okay, just look at me on the screen, because this is an important concept which I want to share with you. Right. Whenever we talk about any muscle spasm stories, that means the muscle has contracted. Just imagine that the lower esophagus muscle is in a state of spasm. Now when the patient is taking some solid food, for example rasgulla. Now rasgulla, what is the rasgulla beta? If somebody do not understand what is the rasgulla, just imagine that it is a circular white color sweet, especially prevalent in the central part of India and the northern part of India. So just imagine that there is a solid food bolus type of thing with the rasgulla, right? Now if there is a muscle spasm in the lower esophagus, when the patient takes the rasgulla, rasgulla has got weight, it is solid food. So when the rasgulla is going down, it puts weight on the muscle and the muscle may relax. If the muscle relaxes, then the rasgulla will go down. Oh, so in muscle spasms, muscular disorders, when the muscles are in a state of contraction or spasm, when the person is taking solid food, the solid food has got weight, and because of the weight, it can put pressure on the muscle and the muscle may relax and the rasgulla can go down. But just imagine, beta, if somebody is taking only liquid, right? Suppose somebody is taking only some juice, or we can try to correlate with the liquid of the rasgulla. If somebody is just taking the liquid, now liquid, beta, will not be having any weight. So what can happen when the liquid is going down here? Because liquid does not have weight, the muscles will not relax and the muscles will remain like this. So the liquid will not be able to go down. That means in achalasia cardia or in any muscle problem or motility disorder, the liquid is not able to pass down because liquid does not have any weight. It cannot relax the muscle. So the liquid gets stuck. So beta, in achalasia cardia, there will be dysphagia for liquids initially. Gradually, as the disease progresses, there may be dysphagia for solids also. Look at me on the screen, beta. This is we try to understand about the muscle disorders. However, in general, as a common sense, if I don't say any muscle disorder, I just say, beta, that there is some tubular structure and now you are creating some traffic jam in that tubular structure because of any reason. What should pass down? Rasgulla should pass down easily or liquid should pass down? Or if I just try to correlate here, if I just try to correlate the story here, suppose I say that this is the wall of the esophagus. There is a dilatation here because distally the lower esophageal sphincter is something like this. Now, if the patient is taking any solid food, in achalasia, so there is a muscle spasm. But suppose I say, let me explain in another picture better. Suppose this is the normal story. And if I say that there is some tumor sitting here in the esophagus, right? Now just focus on this picture, beta. If I say that there is a tumor in the esophagus here, and now the patient takes some solid food, the solid food is coming down, the solid food is coming down. So if there is a mechanical obstruction like a tumor, the solid food will face difficulty. So ideally there should be dysphagia for solids. But if I say that this patient is taking liquids, now what should happen? The liquid should pass down, right? So in normal situations or just a basic common sense, whenever there is any traffic jam type of situation due to mechanical obstruction, liquids will pass down, but solids will get stuck initially. So in all these mechanical obstruction, there will be dysphagia to solids initially. Gradually, if suppose the obstruction increases to enormous extents, then the patient may have dysphagia for liquids also. But in achalasia cardia, which is a problem of the muscle, what happens when the solid food is coming here? The solid food has got weight, and because of the weight, the solid food relaxes the muscle and the solid food can go down. But if the patient is taking only the liquid, then since liquid does not have any weight, so the liquid cannot relax the muscle and the liquid gets stuck. That is why in all look at me, in all motility disorders of esophagus, whether it is achalasia cardia or diffuse esophageal spasm or nutcracker esophagus, whenever the muscles are into a state of spasm, liquids will not be able to pass easily, but solids, because of the weight, can easily pass. So in motility disorders, there will be dysphagia initially for liquids. Otherwise, if it is not a motility disorder, it is some other cause of obstruction in the esophagus. The dysphagia initially will be for solids. Let's have a clap for all of you. I hope, since this is something in ecclesia cardia which is against the common sense, that is why the MCQ people keep on asking this question कि बेटा ecclesia cardia में बताइए dysphagia पहले किसके लिए होता है? So dysphagia in ecclesia cardia is first for liquids. Gradually, if the disease progresses too much, there can be dysphagia for solids also, right? Okay, ji. So dysphagia initially is for liquids. बात समझ आई ना? Gradually there will be dysphagia for both liquids as well as solids. अच्छा, gradually ये बोल रहे हैं कि there will be dysphagia for both liquids as well as solids. So what will happen? Gradually, the solid food will also start staying in this particular area, right? So there is a traffic jam type of situation developing. The proximal people are also getting dilated. Pressure in the proximal part will increase, and there is a chance of regurgitation. And whenever there is a regurgitation, beta, there is always a chance of aspiration and pulmonary complications. So, if we have got this concept, whenever there is a traffic jam in the esophagus, the proximal people are getting dilated, and there is always a possibility that food will regurgitate. And that is the reason why the commonest complication in all traffic jam situations of the esophagus, we find pulmonary complications, lung complications, right? Okay. Sometimes what will happen, beta, if suppose the food is staying inside this area for a long period of time, this food will cause some damage to the mucosa also. Suppose this is the innermost layer of the esophagus, the different layers in the esophagus, beta. The innermost layer is the mucosa, then outside the mucosa there is submucosa, and outside the submucosa there is muscle layer. Outside the submucosa there is a muscle layer. These are the different layers of the esophagus. Esophagus does not have serosa, beta. Serosa is present only in those areas of the body where God has given peritoneum, and peritoneum is something seen in the abdomen. This esophagus is in the thorax, so there is no serosa. Now what will happen? If the food remains here for a long period of time, it will keep on irritating this mucosa, and gradually this mucosa will get inflamed. Inflammation of the esophagus will be called as esophagitis. क्या बोलेंगे बेटा? Esophagitis, right? So now this mucosa is getting inflamed. Esophagitis, right? If this irritation persists, for a long period of time, beta, then this mucosa will start getting damaged. Sometimes erosions can develop, or you can say ulcer can develop here, right? Ulcers can develop. Or if the irritation persists even for a long period of time, then cancer can occur. That means ecclesia cardia traffic jam situation, staying of food matter in this area, esophagitis, ulcers, erosions, and cancer can occur. Herein I would like to explain you an important concept, beta. Again, because this is the story of the concept, very crucial and very important for the understanding for 17th of December as well as your clinical practice as a doctor in future. ध्यान से सुनिएगा बेटा, बिल्कुल एकदम. First of all, I'll explain this in English and then I'll explain this in Hindi, right? Whenever we talk about any cancer in the body, generally speaking, there are only two main reasons. Either it is a genetic issue, maybe some mutations or something developing, or it is the lifestyle of the person, the environmental factors. In the environmental factors, whenever there is a long term irritation of any particular area by somebody, then that particular area which is getting irritated will tolerate for some time. But a day will come when that area would like to protect itself. And sometimes, in order to protect itself, that area starts undergoing mitosis, uncontrolled hyperplasia, uncontrolled mitosis. This can lead to cancer. I repeat this in Hindi. जब भी हम किसी कैंसर की बात करते हैं बेटा, तो कैंसर होने के दो मुख्य कारण होते हैं. या तो कोई जेनेटिक फैक्टर रहा होगा, जो हो सकता है विरासत में मिला हो, किसी जीन वगैरह की म्यूटेशन हुई हो, या जैसी हम जिंदगी बिताते हैं, हमारी जो लाइफस्टाइल है, हम क्या खाते हैं, क्या पीते हैं, जब भी इन फैक्टर्स की वजह से कैंसर होता है ना बेटा, तो हमेशा ऐसा कहा जाता है कि कैंसर एक दिन में नहीं होता, कैंसर को होने में बरसों लगते हैं. जैसे स्मोकिंग की हम बात करते हैं, it is not that if somebody smokes 1 cigarette or 10 cigarettes in a day or maybe 500 cigarettes in a day, next day he'll develop cancer. But if somebody is continuously smoking 2 packs, 4 packs of cigarettes for a long period of time, maybe 10, 15, 20, 25, 30 years, then the chances of cancer are high. I'll come back to Hindi. ऐसा नहीं होता बेटा कि किसी भी इरिटेटिव एजेंट की वजह से एक दिन में पेशेंट को कैंसर हो जाएगा. कैंसर होने में बरसों लगते हैं. ऐसा नहीं होता कि अगर मान लो किसी के मन में आए कि भैया आज जो है मैं 100 सिगरेट फूंक दूंगा या 500 सिगरेट फूंक दूंगा तो मेरे को कल कैंसर नहीं होगा. लेकिन हाँ, अगर मैं लगातार 2, 3, 4, 5 पैकेट सिगरेट बरसों तक पीता रहूंगा, 10 साल, 20 साल, 30 साल तक, तो कोई दिन तो ऐसा आएगा जब मेरे शरीर की म्यूकोसा बर्दाश्त नहीं कर पाएगी और वो अपने आप को बचाने के लिए रैपिड माइटोसिस करेगी. इससे कैंसर होता है. इंपॉर्टेंट, जैसे हम एग्जाम्पल्स की बात करते हैं बेटा कि टोबैको chewing is associated with oral cancer. It is not that if somebody is chewing tobacco, say 100 grams of tobacco in 2 days, and he'll develop cancer the next day. But if he's continuously chewing that tobacco for a long period of time, and there are people who have the habit of keeping that tobacco somewhere between the lips and the teeth, right? Then what is happening? The mucosa of the buccal region that is continuously coming in contact with this tobacco for a long period of time for over years, then gradually the mucosa is getting irritated. And now a day might come when this mucosa may try to protect itself by undergoing mitotic changes, and that can develop cancer. I hope you are able to understand this concept better. This is something we keep on using in oncosurgery very often, right? Chale. So now let us see what all can happen in achalasia cardia story. Most common clinical presentation for achalasia cardia, generally better, let me tell you, the age group of these patients, this is somewhat 25 to 40 years of age. 25 to 40 years of age. Most common clinical presentation is dysphagia, initially for liquids, gradually for both liquids and solids. There is a risk of regurgitation, aspiration, and pulmonary complication. Esophagitis can occur. Here the MCQ people may ask you, beta, which part of the esophagus will have more chances of esophagitis and cancer? Look at me on the screen. If the examiner says, is it the upper part of the esophagus? Is it the middle part of esophagus? or is it the lower part of esophagus? Which part of the esophagus will have more chances of esophagitis and cancer? Whether it is the upper part, the middle part, or the lower part? The answer is very good. So remember beta, in ecclesia cardia, though there is a traffic jam of the lower esophagus, but all the food is getting stayed in the middle esophagus. Esophagitis and cancers, they occur in the middle esophagus. Traffic jam is in the lower esophagus, but esophagitis and cancer will be in the middle esophagus. Okay, G. So esophagitis, this will be seen in the lower part of esophagus, and squamous cell carcinoma will, esophagitis will be seen in the middle part of esophagus, beta. Middle part, I'm sorry. If we compare, we know the problem, the basic pathogenesis is lower esophagus. But whatever changes we are seeing esophagitis and cancer, that will be in the middle part of esophagus. So esophagitis in the middle part of esophagus, squamous cell carcinoma also in the middle part of esophagus. Right? Why there will be squamous cell carcinoma? There was a question even on 4th of June, and should I give you the concept now, or should I wait till oncosurgery? I think I should give it now. Okay, beta. So what type of cancer occurs in which part of the body? In the history of FMG exam, what we have been seeing the last 20 years, there is always one question related to this concept. They might give you some area in the body and they ask you, Acha beta, tell me what is the type of cancer, whether it is squamous cell carcinoma, adenocarcinoma, transitional cell carcinoma, or something else. So understanding and answering this question is absolutely simple. It is just a cakewalk. For example, if suppose I am talking about the pharynx, the esophagus, and then the stomach. Right. Now here beta, this part what you are seeing, this is the pharynx area. Below the pharynx is the esophagus area. And then comes the stomach. Okay, though we'll be drawing this in detail in oncosurgery, but just for the concept, then you know beta, there is duodenum, there is jejunum, there is ileum, there is cecum ascending colon, there is transverse colon, then there is descending colon, then the sigmoid colon, and then comes the rectum, and finally there is the anal canal. Right? Now, if you just take a look at this particular picture, beta, the brown area what you are seeing here, all this area, right? This area is protected. Actually speaking, if you look at your skin, you are having a protective lining on your skin, squamous lining. Wherever your body needs protection, God has given you a squamous lining. कैसी lining दिया बेटा? Squamous. So, malignancy in all these areas will be squamous cell carcinomas usually. Like if we talk about skin cancers, then all over the skin we find the squamous cell carcinoma. Also, I would like to tell you beta, area near the natural openings of your body. Area near the natural openings of the body. Now, if you just try to understand what I'm trying to say, you can just close your eyes for a moment and just try to listen. Areas near the natural openings of your body. Natural openings, the nasal openings, the mouth is there, the tympanic membrane is here. Then, if we go down, God has given the anal opening. Then there is a urethral opening. In females, there is a vaginal opening. So, area near the natural openings of your body require more protection. So, God has given you squamous lining in all these areas. In the mouth, beta, God has extended this protective lining right up to the esophagus, because mouth is something which you keep on using more frequently, right? Okay, that means malignancy near the natural openings of your body will be squamous cell carcinomas, right? Now, if the MCQ people ask you a question, beta, tell me what is the oral malignancy? Squamous. Pharynx malignancy, squamous. Esophagus malignancy, squamous. Anal canal malignancy, squamous. Rest of the entire area of GIT, stomach, duodenum, jejunum, ileum, colon, rectum, here God has given you columnar lining. Now, columnar is something which is needed for secretions. So, wherever secretions has to happen, God has given us columnar lining. And cancer in all these areas is columnar, adenocarcinoma, right? If we try to understand the concept once again, beta, wherever protection is needed, God has given us squamous lining. If we talk about the GIT, the area near the natural openings of your GIT will have to be lined by squamous. So, oral cancer, pharynx cancer, esophagus cancer is squamous, anal canal cancer is squamous, but rest of the areas which are inside, they are supposed to secrete something. So, God has given columnar lining there. Malignancy developing in columnar lining areas will be a adenocarcinoma. So, if they ask you stomach cancer, duodenal cancer, jejunal cancer, ileal cancer, cecum cancer, ascending colon, transverse colon, descending colon, sigmoid colon, rectum cancer will be adenocarcinoma. एनल कैनाल कैंसर, स्क्वामस. अच्छा बेटा, एक बार करते हैं इसको. कैंसर इन द ओरल कैविटी और माउथ, स्क्वामस. फेरिंग्स, स्क्वामस. ईसोफेगस, स्क्वामस. एनल कैनाल, स्क्वामस. स्टमक, ड्यूडेनम, जेजुनम, आइलियम, कोलोन, रेक्टम, एडिनोकार्सिनोमा. एक बार फिर से करेंगे बेटा. मैलिग्नेंसी इन द ओरल कैविटी, फेरिंग्स, ईसोफेगस, एनल कैनाल, squamous. Malignancy in stomach, duodenum, jejunum, ileum, colon, rectum, adeno. हुआ बेटा? एक बार फिर से करते हैं. Common cancer in the oral cavity, pharynx, esophagus, stomach, duodenum, jejunum, ileum, colon, rectum, anal canal. Very good. एक बार फिर से करते हैं बेटा. Cancer in the stomach, esophagus, colon, oral cavity, anal canal, duodenum, esophagus, oral, anal, esophagus, pharynx, stomach, colon. Wonderful. Very good. Now, if we take a look at that picture, beta, see how simple it is. There is nothing to cram. It is so very simple. है ना? अगर हमें कॉन्सेप्ट समझ में आ जाए तो फिर हमें सर्जरी में, क्योंकि सर्जरी इज सिंपल कॉमन सेंस बेटा, है ना? अभी इसमें देखो, all the brown areas what I have drawn. Can you correlate what we learned? Whether it's a oral cancer, pharynx cancer, esophagus cancer, this is squamous. Then all the stomach, duodenum, jejunum, ileum, colon, rectum story is adeno. And then again we have to come out. So God has given protective lining in the anal canal and there is a squamous cell carcinoma here, right? जिसकी जैसी lining उसका वैसा कैंसर. The part, whatever is the lining there, that is the commonest cancer. Right? I hope you'll be able to remember this. Good. So that is the reason, beta, why you will find squamous cell carcinoma in the esophagus. Okay? Right. चलिए बेटा आगे बढ़ते हैं. Just imagine February 23, you are the boss, and suppose a 35-year-old lady is sitting in front of you in your OPD, outpatient department, with dysphagia. Now, how to approach? Generally, we know that we take the history and then do the examination and everything. So, you take the history, and the lady might be telling you that when she is taking some juices or something, थोड़ा सा AC कम कर दीजिएगा, ठंडा ज़्यादा है. Right. So, basically, this 35-year-old lady sitting in front of you in the OPD, she's telling you that, doctor, when I'm taking some juices or when I'm swallowing the water, I feel that there is something, and I'm not able to swallow the water properly. Might be, I feel that there is some traffic jam type of situation. Okay? You are listening to the patient. Now, you feel that this patient is having dysphagia. You may ask, Acha, tell me what happens when you're taking some chapati or maybe some veg biryani or maybe some idli. What happens to the idli? Does it go down? Doctor, when I'm taking that idli, then that idli actually goes down. Sometimes I feel there is a sense of obstruction somewhere, but yeah, idli can go down. But when I'm taking the rasam or maybe the sambar, then I feel that I'm not comfortable. Okay, so in clinical examination, you can do inspection, palpation, percussion, auscultation. Inspection, you are looking at the lady, nothing. Palpation, there is hardly anything which you will be able to elicit on palpation. Percussion, if there is a traffic jam here, will the rasgulla be producing any sound? Will the idli be producing any sound? No. Auscultation, idli does not have any sound, right? So clinically, we are not able to diagnose what is the problem. So any patient who is presenting to you with dysphagia, it is better to do some investigation. And the first investigation generally we are doing is a barium swallow. First investigation in any patient presenting with dysphagia, it is barium swallow. When you ask the lady to swallow the barium beta, you can imagine what is going to happen. This contrast is going nicely in the esophagus. This is the normal story beta. The contrast has actually passed down. That is why you are not seeing a white shadow here, but actually this will also be white. Okay, so this is something like this. Now you can just imagine that the contrast is going down, down, down. This contrast is going down. But there is a traffic jam further. So till here the story is okay. But now you will start seeing that tapering type of thing. Right? The tapering type of thing. Here also you are seeing something like this. Then you are seeing something like this. And then you will be seeing something like this. And then what you are seeing is something like this. This classical appearance, what you are seeing here, is just like a bird beak. It is like a bird beak appearance, right? Or you can say the pencil tip appearance, This is a pencil tip appearance, right? This classical appearance is seen in eclasia cardia, and this is because of the spasm of the lower esophageal sphincter. This is a hot X-ray image or a barium swallow image, what you are seeing on your screen beta. This question has been asked 3 times in the last 6 exams. पिछले 6 एग्जाम में से 3 एग्जाम में ये फोटो आई है. And they have asked you to identify the pathology in this image. Okay. There can be other images of eclasia like this picture. This has also been asked. Here, can you see the classical bird beak type of appearance बेटा? चोंच बन गई ऐसे, है ना? जैसे चिड़िया की चोंच होती है, उस तरह से दिख रहा है. This is the lower esophageal sphincter area where only a thin rim of contrast is passing down. Right? So this classical tapering, what you are seeing, this is the bird beak appearance or the pencil tip appearance. This thin rim of contrast going through the lower esophageal sphincter, this looks like the tail of the rat. चूहे की पूंछ जैसा दिखाई देता है. This is the tail of the rat, what you are seeing. Here, proximally, this is the body of the rat, and here, this is the tail of the rat, right? So this is a rat tail appearance. And many a times, because contrast is not going properly into the stomach, so the stomach air bubble, what we commonly see, is not visible in eclasia cardia. If we try to focus here, beta, then the pinky thing, what you're seeing, this is actually the barium, the contrast which is going down. So here in this area, you may see the nice filling up of the contrast. The middle part of the esophagus would be dilated, but then gradually what is going to happen, beta, here as you go down, there will be tapering, what you will be able to see. And then this is the classical bird beak, what we are seeing. Only a thin rim of contrast would be passing through the lower esophageal sphincter area. And this is what we can call as rat tail appearance. And since good contrast is not going, so the stomach is not filling properly, normally when we take the x-ray, we find a normal gas shadow here in this area, and that is because of fluid present here. But in this case, since nice amount of contrast is not going, so we may not see the classical air bubble inside the stomach. If we try to correlate here with this appearance, what we are seeing here, this is actually the bird beak appearance. Bird beak appearance. Or we can say the pencil tip appearance. Pencil tip appearance. This thin rim of contrast, what is going here, this is what we call as rat tail appearance. क्या बोलते हैं बेटा इसको? Rat tail appearance. अच्छा, if you are not able to see the stomach air shadow nicely, we call this as absence of gastric air bubble. Absence of gastric air bubble. These are the findings what you can see on barium swallow in eclasia cardia, right? ठीक है बेटा, the first investigation what we are doing here, this is the barium swallow. Where we can see the bird beak or pencil tip, rat tail, and absence of gastric air bubble. Now we should not confuse these images with images of cancer in the esophagus. If we are talking about a cancer in the esophagus, let us try to reproduce a cancer in these images. Suppose I say, beta, that this is the normal story of esophagus. Suppose I say, beta, this is the normal story of the esophagus. And if I say, when you are doing the contrast will be filling somewhat like this, and you will be seeing the esophagus somewhat like this. This is the normal story. Now, if I say that if there is some cancer developing here, then what is going to happen? If suppose I say that there is a cancer developing here, now when you are giving the contrast, beta, will this contrast be going inside the cancer? क्या ये दवाई कैंसर के अंदर जाएगी? जो लिक्विड है, Can this go inside the cancer tissue? No, cancer is a mass, it's a tissue. The contrast is actually going into the lumen. So the contrast will be going through the side of this, right? Through the side of this. For example, we may find the contrast somewhat like this. I'm sorry. Suppose this was the esophagus and here was the cancer. Now when you are giving the contrast, here the contrast will be flowing nicely, but here the contrast will not be flowing nicely. Rather, the contrast will be filling around the cancer, and now the contrast will be going down like this. Okay, so when you take the X-ray, what you actually see on the X-ray, beta, you just see the contrast. If you see only the contrast, that means you'll be seeing the story something like this. This area which is not getting filled by the contrast, this is called as a filling defect. Filling defect. क्या बोलते हैं बेटा इसको? Filling defect. The contrast is not filling the cancer. So this is the filling defect. And here what you can see, there is a thin rim of contrast flowing from the side. Now if suppose there is a traffic jam type of situation, what we are seeing here, what can happen? The proximal people might get dilated. So we may see some dilatation in the proximal part here. Now when we just try to see this, this looks as the body of the rat and this looks like the tail of the rat. ये चूहे की बॉडी दिख रही है बेटा और ये चूहे की पूंछ दिख रही है. तो if there is a cancer in the esophagus, then we find a filling defect and a rat tail appearance. Rat tail appearance? Rat tail appearance तो अभी हमने यहाँ पे लिखा है. Rat tail appearance is this. This is also a rat tail appearance and this is also a rat tail appearance. But this is a classical rat tail appearance. So if you get a question, rat tail appearance is seen in, and there is an option of cancer esophagus as well as achalasia cardia, then cancer esophagus will be a better option for rat tail appearance. Okay beta? Cancer esophagus will be a better option for rat tail appearance, right? So in malignancies, if we just try to see what actually we are seeing on the contrast studies, ध्यान से देखो बेटा, can you appreciate here? You are not seeing any contrast in this area. This is a filling defect. You are not seeing any contrast in this area also. यहाँ भी नहीं दिखाई दे रहा ना बेटा. This is also a filling defect. And this thin rim of contrast, what you are seeing here, this is what we call as the rat tail appearance. बात बन गई ना बेटा अपनी, है ना? So that is how we will be able to differentiate the images of achalasia cardia and cancer esophagus. These are hot images, right? चलिए, so February 23 में वापस चलते हैं. You are in the OPD, 35-year-old lady, dysphagia. You have done a barium swallow and you can see the classical bird beak, pencil tip, rat tail and absence of gastric air bubble appearance. You are getting an idea ki yes boss, this can be a case of achalasia cardia. Now if it is a achalasia cardia, that means there would be absence of ganglion cells in the nerve plexus. There is traffic jam at the lower esophageal sphincter. It is a muscular problem. There are other motility disorders also in the esophagus, which are nutcracker esophagus and diffuse esophageal spasm. Diffuse means the entire esophagus, right? So, how can we say that this is actually achalasia cardia and not any other motility disorder? For that, we have got a simple investigation, which is manometry. Manometry is just the pressure study. In Hirschsprung disease also, beta, in pediatric surgery, we do a anorectal manometry there. Here in ecclesia cardia also the standard investigation what we consider is a manometry. So when we are measuring the pressure inside the esophagus, depending on what is the pathology, we can find different pressures in the esophagus. Like in ecclesia cardia, normally beta the intraesophageal pressure is 10 to 25 millimeter of mercury. In ecclesia cardia, this pressure is between 25 to 100 millimeter of mercury. Nutcracker esophagus, the pressure is more than 180 to 200 millimeter of mercury. In diffuse esophageal spasm, this pressure can go even beyond 300 to 400 millimeter of mercury. So on the basis of pressures inside the esophagus, we can segregate these different conditions. That is why we say कि भैया standard investigation in ecclesia cardia is a esophageal manometry. Concept के लिए क्या याद रखेंगे बेटा? Whenever there is any motility disorder, any muscle spasm disorder in all 19 subjects, जब भी मसल की समस्या होगी ना बेटा, अगर मसल स्पाज्म में जाएगी तो ऊपर का प्रेशर बढ़ेगा और उसके लिए अपन प्रेशर मेजर करेंगे, मैनोमेट्री करेंगे. ओके, एनी मस्कुलर डिसऑर्डर व्हेन द प्रेशर इज हाई, यू कैन डू अ मैनोमेट्री. Another hot image based question. Now this question has been asked twice in the last 5 exam. पिछले 5 एग्जाम में 2 बार पूछा है. This has not been asked on 4th of June. आप समझदार हैं, right? Whether it is ecclesia cardia photo, this photo, this photo, this has not been asked on 4th of June. This photo has also not been asked on 4th of June. And as a surgery faculty for you, beta, my gut feeling is that you will be getting any of these 2 photos on 17th of December. And then you might recall कि sir ने बताया था कि this image can come. There are very high chances of this image coming on 17th of December. Okay? In diffuse esophageal spasm, beta, what happens? It is a diffuse condition. That means the entire esophagus is getting affected. There are multiple spasms at different places in the esophagus. दिख रहा है ना बेटा, narrowing जगह जगह पे अपने को पतला पतला दिखाई दे रहा है ना. At different places you are finding this narrowing, and proximal to the narrowing there will be dilatation. Here this is the narrowing. Here this you are seeing is a dilatation. Same story here, same story here. There is a narrowing here and there is a dilatation here. So when it is involving the entire esophagus, diffuse esophageal spasm, we find this type of appearance which we call as corkscrew esophagus. Corkscrew esophagus. If I just remove myself, बेटा ध्यान से देख लो और इस फोटो को बिल्कुल अपने दिल में बसा लो. This what you are seeing. This is the diffuse esophageal spasm. Diffuse esophageal spasm. Can you see the narrowings and the dilatations? Right. Okay. Fine, beta. Diffuse esophageal spasm. This is diffuse esophageal spasm on barium swallow. It gives a corkscrew esophagus. Very hot question. Corkscrew esophagus. Right. Now beta, what should be the treatment for this? Simple. समस्या क्या है? What is the problem? The problem is that there is a spasm of the sphincter. The muscles in this area have gone into spasm. If you are able to dilate these muscles, if you are able to relax these muscles, the traffic jam will get cleared and all the story will pass down nicely. In order to relax these muscles, beta, we can give some calcium channel blockers and nitrates type of medicine which can relax the smooth muscles. CCBs and nitrates. They were also used in Raynaud's disease. They were used because in Raynaud's, there was a spasm of the arterioles. So by giving CCBs and nitrates, they used to relax the smooth muscle in the arterioles. Here the CCBs and nitrates will relax the smooth muscle of the lower esophageal sphincter. And if they work, the traffic jam will be cleared and the story will start passing down and the patient will be happy, right? But sometimes, beta, these medicines are not sufficient. Then what you can do, you can try passing a balloon catheter. Now, in this balloon catheter, what you can do is, suppose you are passing a balloon catheter like this. What you can do, you can keep the balloon at this area, right? You just keep the balloon at this area. And now you have the option that you can just dilate this balloon. If you dilate this balloon, then this area can relax. This is the pneumatic balloon dilatation. But the best results what we get is when we incise these muscles. Like here, beta, just to remind you, here there will be mucosa. The mucosa here, suppose, is compressed. Then outside there is submucosa. And outside this is the muscle layer. So here is the muscle layer. And what is the basic problem, beta? The muscles are not able to relax. The muscles are getting tightened. Because of this, there is narrowing of the lower esophageal sphincter. So the best results what we can do, beta, we can take a knife and we can just incise these muscles. If you just make an incision on these muscles, then this muscle is going to relax, okay? And this is, as soon as the muscle relaxes, beta, this area will open up and the food will start going down. Whenever we are opening the muscles, we call it as myotomy. In pediatric surgery, there is a condition called as hypertrophic pyloric stenosis, where there is thickening of the pyloric musculature. In order to relax the pylorus, we are making a longitudinal incision over the serosa and the muscle. Since in the stomach, first we have to cut the serosa, then only we can cut the muscle. So that is called as a seromyotomy. But in achalasia cardia, there is no serosa here. We can directly cut the muscle. So we call it as myotomy. Also, beta, generally we were doing a operation laparoscopically. So we were approaching the esophagus from this side. This operation, when we are just cutting the muscle laparoscopically or by open surgery, we call it as Haller's operation. Haller's operation. However, we have the option of cutting the muscle by endoscopic approach also. You can pass the endoscope from the mouth. You can pass the endoscope from the mouth. And what you can do, beta, just imagine that you are trying to pass an endoscope from the mouth. Now, when you pass the endoscope from the mouth, you can pass an instrument, or you can even pass this endoscope. Here you are going into the lumen. But what you can do is, you can create a tunnel beneath the mucosa. That means now you are going into the submucosa. Dikh raha hai beta? Yeah. So you are going into the submucosa. You have created a tunnel. The endoscope is here. Now when you keep the endoscope here, then from inside the endoscope, you can pass another instrument. This would be having a knife. And now you can cut the muscle from inside. This is also a myotomy. But the advantage here is you are not making any incision on the abdomen for laparoscopy or open surgery. You are just going from inside the mouth. That means without making any incision over the body, if you can pass the endoscope through a submucosal tunnel, you can cut this muscle. So which will be better, beta? The outside where you are making incision on the body or the endoscopic? It will be the endoscopic. And you know what this endoscopic procedure is called as? This is called as पोयम. पोयम 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 मतलब पोयम, बच्चे पोयम गाते हैं ना, पोयम. पर ओरल यानी मुंह से, थ्रू द माउथ. एंडोस्कोपिक मायोटोमी. पर ओरल endoscopic myotomy. So this is what we can do in the treatment of achalasia cardia. Our motive in the various modalities of treatment is that we have to relax the muscle. इस muscle को relax करना है ना बेटा. अब या तो हम दवाइयाँ देते हैं, either we are doing it with medicine, CCBs or nitrates, or we were doing a endoscopic balloon dilatation, or we can do a myotomy, whether from outside Hellers or by creating a submucosal tunnel. Right? This is poem. Best results by the myotomy. Right, beta. देख लेते हैं जी क्या लिखा है इसमें. In the treatment of achalasia cardia, initially what we are doing is we are giving some drugs like calcium channel blockers and nitrates. We can do a pneumatic balloon dilatation, but sometimes what happens, beta, when we are passing this balloon, just look at the screen for a moment. Let me just try to recreate that situation for you. Suppose I say that we are passing a balloon catheter here, right? And now when you have to inflate the balloon, you are not seeing inside. The end of this is here. You are only seeing this end. So you just imagine that you have taken the balloon at the site of stenosis or maybe spasm area. And now you are putting the air. यहाँ से you are putting the air. When you are putting the air, the balloon has to dilate. Now suppose suddenly a beautiful staff nurse comes around, and when you are injecting the air into the balloon, suddenly your focus shifts toward the staff nurse. Then you may tend to over-dilate this, and this may cause rupture. This question has also been asked in the NEET PG exam, beta. Which modality in the treatment of achalasia cardia carries the risk of rupture of esophagus? So it is the pneumatic balloon dilatation. Risk of esophageal rupture. Treatment of choice is surgery. SX means surgery. And in surgery, what we are doing, beta? We are doing a myotomy. Okay. Now we are doing a Heller's myotomy. Heller's myotomy or a Heller's operation. Hypertrophic pyloric stenosis in pediatric surgery, 17-day-old baby. Ramstead seromyotomy. Achalasia cardia, 35-year-old lady. Heller's myotomy. No serosa. There is no serosa in the esophagus. This can be done either by open surgery or by laparoscopic surgery. Either by open surgery or by laparoscopic surgery. Okay. Nowadays, we have the facility of POEM. POEM is per oral endoscopic myotomy. Per oral endoscopic myotomy. Now, sometimes what can happen, beta? When we are cutting the lower esophageal sphincter, then the lower esophageal sphincter can relax abnormally. And if it relaxes abnormally, it can lead to reflux of gastric contents into the esophagus. And to avoid that, we are doing a fundoplication. I'll just show you a video beta here that how this reflux can occur. This is something normal, right? This is the lower esophageal sphincter na beta. So normally it is contracted and it allows the passage of food from above downwards only. But sometimes if you damage the lower esophageal sphincter beta, now just see what will happen. If this sphincter is over relaxed, now what can happen? Normally the food is coming like this. Normally the story is coming like this. But if this is damaged, look here. What will happen? The acid which is there inside the stomach, the acid will reflux, and this acid here will cause heartburn or retrosternal pain, right? In these situations, beta, if we have to do some surgical intervention here, then what we can do is, see, if the patient is having reflux and you have to do surgery to avoid reflux, you can just take the help of this fundus of the stomach, take it all around the esophagus and try to give some support around the lower esophagus. Something like this. See? Once again you see how we are taking it and we have rotated it around the esophagus. And this is going to give the outside support. So now the chances of reflux will not be there. Once again, let us see, beta, that what we were actually talking about. Normally, normally what happens? Normally, the lower esophageal sphincter remains tight, and because of this, the food is allowed to go down. That's it, like this. But whenever the lower esophageal sphincter is damaged, here in eclasia cardia, beta, आप चाकू चला रहे हैं इसके ऊपर. You are making a longitudinal incision by myotomy in eclasia cardia treatment. So the complication which can occur is, if you are damaging the lower esophageal sphincter, then there are chances that acid which is there inside the stomach, because of the damage here, the acid may go up into the esophagus, right? So can you see the acid in the esophagus? If acid is going in this area, this is going to cause heartburn, right? So the patient presents with heartburn. The commonest presentation of GRD is heartburn. Dil jalta hai, right? And now, when we are doing surgery for eclasia cardia, in those cases, if we feel that bhaiya, we have done a nice myotomy and the chances of reflux are there, then at the same time, to avoid reflux, you can just wrap the fundus of the stomach all around the lower esophagus. You can just wrap the fundus of the stomach around the lower esophagus just to give the outside support. So after myotomy, if you have to avoid reflux, we do a fundoplication, wrapping the fundus of the stomach around the lower esophagus. Right, beta? Okay. Now if we come back here, so to avoid reflux, what we are doing is a fundoplication, right? And the last thing in dysphagia here is a Schatzki's ring. Now Schatzki's ring, beta, it is just a ring of the mucosa or submucosa. Look at the screen, beta. Just imagine that you are passing the endoscope from the mouth and you have taken the endoscope right into the lower esophagus. Sometimes what you can find in the lower esophagus, beta, this area which is towards this side, this is the esophagus. And this area which is inside, this is the stomach. Sometimes what we can find when we are doing the endoscopy, at the squamocolumnar junction, that means very close to the junction of stomach and duodenum, very close to the junction of esophagus and the stomach, we can find a circumferential ring-like structure. Dikh raha beta ye ring-like structure? This is what we call as Schatzki's ring. And sometimes, because this ring is coming into the lumen, when the patient takes the rasgulla, this ring may create some turbulence and the patient can have dysphagia because of this ring. But many a times we have seen that suppose the patient is taking the rasgulla or suppose the patient is taking the entire idli, right? Now when the idli is going inside, the idli puts pressure on this ring. चारों तरफ ऐसे pressure मारती है and it relaxes the ring and the idli goes down easily. So idli itself can do the treatment for this Schatzki's ring. It can relax the ring. The solid food can relax the ring. Okay. So these Schatzki's ring patients sometimes can present to us as intermittent dysphagia. Another story is a lie stricture. Now this lie stricture, can you see this what you're seeing, beta? This is actually the image of esophagus. This is a contrast swell or a barium swell of the esophagus. Can you just see how the esophagus has thinned out? Kitna patla ho gaya hai? Now this lie stricture is because of ingestion of alkali, ingestion of castics. Sometimes what happens? Okay. Just excuse me. Oh, charger चाहिए. Right, beta. So sometimes what can happen, beta? If suppose somebody ingests the alkali, अगर मान लो किसी का मूड खराब है और वो अपनी जिंदगी से परेशान है, सपोज अकेला है घर में, टॉयलेट में गया और टॉयलेट में वो फिनाइल वगैरह रखा होता है, फिनाइल की बोतल खोली और फिनाइल पी लिया. Now this phenyl is going to cause intense injury. I'm just trying to give an example, beta, that if suppose somebody is frustrated with his life, he's all alone at his home, he goes to the toilet, sees that phenyl bottle, that toilet cleaner or Harpic, he just opens that Harpic and he swallows the Harpic. Now, if somebody ingests the alkali, beta, alkalis are much more dangerous than acid, and this may cause intense inflammation of the esophagus, which will lead to healing by fibrosis. And whenever we talk about fibrosis, it causes narrowing. And this what you are seeing is a stricture. The term lye, L-Y-E, is a specific term which is meant for alkali. Okay. So this is what can happen. Schatzki's ring, beta. This is a circumferential mucosal submucosal thickening at the squamo-columnar junction. At the squamo-columnar junction, commonly seen in GERD patients, right? This ring is common in GERD patients. Sometimes can lead to dysphagia, which we call as intermittent dysphagia. If the patient keeps on coming to you with problems, beta, you can simply pass an endoscope and dilate the ring. That is curative. So single endoscopic dilatation is curative for Schatzki's ring. Lye stricture, beta. Lye stricture is due to ingestion of castics. This is the keyword what they want to elicit in the exam. This is alkali. And this can cause intense inflammation of the esophagus and lead to this lye stricture. Okay, beta. So if we just try to quickly summarize what all we have discussed in dysphagia story. So, ek bari, let us just try to summarize this dysphagia story quickly. Just close your eyes, beta, and let me just revise this dysphagia story for you. Dysphagia, that is difficulty in swallowing, can be due to causes like Zenker's diverticulum, eclasia cardia, nutcracker esophagus, diffuse esophageal spasm, Schatzki's ring, and lye stricture. Zenker's diverticulum is also called as pharyngeal pouch or cricopharyngeal eclasia. Usually, in elderly people, if the tone of the cricopharyngeal sphincter is tight, pressure in the pharynx will be more, and this will cause outpouching of the posterior pharyngeal wall posteriorly above the cricopharyngeal sphincter through the Killian's dehiscence inferior constrictor muscle between the thyropharyngeus and the cricopharyngeus muscle. right beta? This is a acquired diverticula, false diverticula, because all the layers are not there, only mucosa and superficial submucosa is there. Usually seen in elderly people, 50% of patients, they can be associated with cervical webs. If the diverticula occurs, it presses the esophagus, so patient will not be able to swallow the food properly. Commonest presentation is dysphagia. Because of stasis of food in the diverticula, there is a chance of regurgitation, aspiration, and pulmonary complications. Because of stasis of food in the diverticula, there can be halitosis. When you clinically examine and try to press the swelling, there is a characteristic gurgling sound which is called as Boy's sign. Now, investigation of choice for Zenkus is barium swallow, and treatment less than 2 centimeters, cricopharyngeal myotomy 2 to 4 centimeter, diverticulopexy more than 4 centimeter, Dolman's operation, which is a diverticuloesophagostomy with a linear stapler. Achalasia cardia is failure of lower esophageal sphincter to relax. There is absence of ganglion cells in the orbic plexus of esophagus, because of which peristalsis is absent. And there is selective damage to the lower esophageal sphincter, because of which lower esophageal sphincter fails to relax. So there's a traffic jam situation. Primary achalasia, exact cause is not known. Secondary achalasia due to some diseases like Chagas disease, diabetes, and cancer esophagus, or even scleroderma. Pseudoachalasia is tumors outside the esophagus, like tumors from the cardia of the stomach or mediastinal tumors. They are pressing the esophagus. Whatever is the reason, if there is a traffic jam in the esophagus because of spasm of the muscles, patient presents with dysphagia, usually 25 to 40 years age group, difficulty in swallowing. Now, in motility disorders or muscle spasms, initially there is dysphagia to liquids, because liquid does not have any weight, so it cannot relax the muscle. Solid has got the weight, so solid can relax the muscle. That is why initially in motility disorders like achalasia, there is dysphagia for liquids. Now gradually the dysphagia will develop for solids. There will be stasis of food in the middle esophagus. There will be chances of regurgitation, aspiration, and pulmonary complications. Because of long stasis, it can cause damage to the esophageal mucosa in the middle esophagus, esophagitis. Squamous cell carcinoma can occur in the middle esophagus in long-standing cases. Our clinical approach in a patient coming with dysphagia in the OPD, first we do a barium swallow. In achalasia, we see a classical bird beak, pencil tip, rat tail, and absence of gastric air bubble. In a cancer, we see a filling defect and rat tail appearance. Rat tail is more often seen in cancer esophagus. By looking at the barium swallow image, we get an idea that yes, this can be achalasia cardia. But to be very sure, we do manometry. We can study the pressure inside the esophagus. Normally, it is 10 to 25 millimeter of mercury. In achalasia, 25 to 100, nutcracker 180 to 100, and in diffuse esophageal spasm, more than 300 to 400. In diffuse esophageal spasm on barium swallow, we find a corkscrew esophagus. In the treatment for achalasia cardia, we just want to relax the lower esophageal sphincter so that the food passes down. And to relax the lower esophageal sphincter, initially we can try treating by medicines like calcium channel blockers and nitrates, which causes relaxation of the smooth muscles of the lower esophageal sphincter. We can also try doing a pneumatic balloon dilatation, but there is a risk of rupture. The best results are obtained by surgical myotomy, which can be done as Haller's operation, maybe open surgery or laparoscopy, or we can do a endoscopic myotomy, POEM, per oral endoscopic myotomy. When we feel that there will be chances of reflux, GRD, after myotomy, then we do a fundoplication. Schatzki's ring is a circumferential mucosal or submucosal ring at the squamocolumnar junction seen commonly in GRD patients, can present with intermittent dysphagia, and a single endoscopic dilatation would be curative. Lye stricture is a stricture in the esophagus seen after ingestion of castics or alkali. हुआ बेटा? रिवाइज हो गया? चलिए अभी क्या करें बेटा? अभी let's take a छोटा सा break, right? 10 minutes break, and then we'll be back and we'll discuss about GRD story. Okay. Right, beta. So now let's take a look at another story, that is surgical chest pain. If we take a look that what all can cause surgical chest pain, beta, then it is GRD. Now what actually happens in GRD? Let us look at that video once again. Now just see. Normally what happens, beta, in normal individuals, this is the esophagus, this is the lower esophageal sphincter. And what is GRD actually is reflux of acid into the esophagus. In all of us normal individuals, the lower esophageal sphincter remains intact, which does not allow the gastric contents to move into the esophagus. Also, if the stomach is emptying nicely, then also the pressure here will be less and the chances of reflux will be less. If I say that suppose the esophageal peristalsis is good, then also good esophageal peristalsis, which is coming from above downwards, will not allow the acid to move from below upwards. Despite saying this, in all of us, beta, we have seen that many a times the gastric contents come back into our mouth. Suppose you eat something spicy or pani puri or golgappa. Now many a times what happens, that spicy liquid that comes back into your mouth sometimes. Does this mean that we suffer from disease? No, because transient lower esophageal sphincter relaxations can occur normally in normal individuals, but the frequency of these relaxations of this sphincter are not more than 3 to 4% of times in 24 hours. Okay? It is when the frequency of these refluxes increase, and if they occur for more than 3 to 4% of times in 24 hours, then we call it as disease, and then we call it as gastroesophageal reflux disease. Right? Now, what can happen? If suppose somebody damages the lower esophageal sphincter, the gastric content comes up and this presents with heartburn. Now we should know that who is the person who actually can cause damage. Why this lower esophageal sphincter gets damaged most commonly? The most common culprit is smoking, alcohol, chai, coffee, hot liquids, spicy food. All these can cause damage to lower esophageal sphincter, right? Sometimes obesity. मोटे लोगों में क्या होता है? If the intra-abdominal pressure is high, then this is going to put pressure on the lower esophageal sphincter and this can become weak, and then the chances of refluxes will be more. Hormones like progesterone, which are also causing weakness of the valves and varicose veins. This progesterone can also cause weakness of the lower esophageal sphincter. Medicines which we were using in the treatment of achalasia cardia, like calcium channel blockers and nitrates, they can over-relax this lower esophageal sphincter. So any of these things, lifestyle of the person, suppose he is continuously busy, he is continuously under stress, the amount of acid production in this patient will be high, and this acid may irritate the lower esophageal sphincter and it can become weak, leading to refluxes. So when the frequency of these refluxes occur for more than 3 to 4% of times in 24 hours, then we call it as disease. And the patient classically presents with heartburn. Sometimes there may be epigastric pain and regurgitation. Now, many times we have seen that complications can also occur because of this GRD. Now, what can be the complications, beta? Suppose Here what you are seeing, this is the squamous mucosa. In the stomach there is columnar mucosa. Now if we try to take a look, because of the refluxes, there will be inflammation in this area, which can lead to healing by fibrosis leading to stricture formation. Sometimes because of these refluxes, ulcer can form here. Ulcer is breach in the continuity of epithelium or mucous membrane, right? Apart from this, Barrett's esophagus, which is something we read in pathology. Now here what happens, just see. Normally beta, the story is something like this. Okay, can you see the nice squamous mucosa here? Now look at me. This lower esophagus, if it is facing the acid continuously, the squamous mucosa is getting damaged. There is esophagitis developing here. So this lower esophageal mucosa is continuously irritated by the acid. Stomach also has got huge amount of acid inside. But the stomach mucosa never complains. Stomach mucosa is never getting damaged. All of you who are watching this right now, beta, inside your stomach, you are having the columnar mucosa. You are having huge amount of acid in your stomach. But despite such huge amount of acid in the stomach, why you all do not suffer from gastritis or peptic ulcers? Because God has given an MCQ inside your stomach, and that is mucus barrier. What happens, beta? The goblet cells, they secrete mucus, and this mucus forms a coating on the surface of the stomach. And because of this mucus on the surface of the stomach, it acts as a barrier. And this mucus barrier does not allow the stomach acid to damage the mucosa. That is why you do not suffer from gastritis or gastric ulcer. लेकिन जब ये barrier टूटेगा, whenever this barrier is going to get destroyed by whatever reasons, whether it is bacteria, Helicobacter pylori, or it is non-steroidal anti-inflammatory drugs, or it is smoking, or alcohol, or hot spicy food, whenever this mucus barrier will be damaged inside your stomach, beta, then your stomach mucosa will come in contact with the acid, and then you will start developing gastritis and peptic ulcers. Okay? Now here we are talking about the Barrett's esophagus story. Normally, the squamous mucosa is not facing the acid, but in GRD, the squamous mucosa is getting irritated. So for some time, the squamous mucosa is able to tolerate this acid. But gradually, this esophageal mucosa is getting irritated. And this irritation tells the patient, look, please stop smoking, please stop alcohol. They are causing irritation in the esophagus. The acid is causing irritation in the esophagus. But the patient does not listen. He continues with smoking alcohol, chai, coffee, and all that stuff. Gradually, this squamous mucosa may give an ultimatum to the patient. Look, it's enough. Enough is enough. If you don't stop, then I will leave you. Basically, if we try to understand this in Hindi now, कुछ समय तक तो ये स्क्वामस म्यूकोसा बर्दाश्त करती है, लेकिन जब इसको ज़्यादा चोट लगना शुरू हो जाती है, पेशेंट को वार्निंग सिग्नल्स देती है कि भाई साहब छोड़ दीजिए, स्मोकिंग छोड़ दीजिए, अल्कोहल छोड़ दीजिए, चाय कॉफ़ी छोड़ दीजिए, जलन हो रही है यहाँ पे, लेकिन पेशेंट है कि मानता नहीं। आदतें जारी हैं, म्यूकोसा का डैमेज जारी है। एक दिन आता है जब ये ईसोफेगस की म्यूकोसा अल्टीमेटम दे देती है पेशेंट को, मानते कि नहीं मानते हो, नहीं मानते हो तो छोड़ के चली जाऊंगी। Now, why this ultimatum? Why the squamous mucosa want to leave the esophagus? Because this squamous mucosa is continuously seeing this columnar mucosa. See how God has given a nice mucus barrier in the columnar mucosa. Despite so much of acid in the stomach, the stomach mucosa is living happily. There is no damage. So now this squamous mucosa also wants to become like this stomach mucosa. The esophageal mucosa also wants to have that mucus barrier. That means who forms the mucus? Goblet cells. So now this esophageal squamous mucosa changes into columnar mucosa. And beta, goblet cells are present in the stomach columnar as well as intestinal columnar. But these goblet cells are much more abundant in the intestinal mucosa. So this squamous mucosa want to have the goblet cell. This squamous mucosa changes into columnar mucosa like the intestine. Intestinal columnar metaplasia. Huge amount of goblet cell. They will secrete mucus and then a barrier will form. And now even if the acid is refluxing, because of the mucus barrier, this can be protected. So basically beta, Barrett's esophagus is actually a protective mechanism where the squamous changes to columnar. Mucus, goblet cells, mucus barrier, just to avoid more damage. And sometimes beta, what can happen? Apart from this Barrett's, sometimes hiatus hernia can occur. Now, hernia is something abnormal protrusion of a viscus or a part of viscus through a defect or weakness in the wall which contains it. If I just try to simplify this, hernia is simply when something goes out, right? Why it goes out? Because there may be more pressure. Like in GERD patients, what is happening here? There is continuous reflux. And because of this continuous reflux, this will force the stomach to move into the thorax. If the stomach goes into the thorax, this is hernia. Usually in GERD, it is a sliding hiatus hernia. Okay, so this can be a complication. What should we do in the treatment for these GERD patients? We don't want this reflux. So first we try to modify the lifestyle of the person. उसको समझाते हैं कि भैया स्मोकिंग छोड़ दो, अल्कोहल छोड़ दो, चाय कॉफी छोड़ दो, हॉट स्पाइसी फूड छोड़ दो. पेशेंट सुन रहा है, फिर पूछ लेता है, इसने कहा उसको छोड़ दो, उसने कहा इसको छोड़ दो, आप कहते हो सब कुछ छोड़ दो. फिर जीने का फायदा क्या है? Basically, you are just trying to modify the lifestyle of this person. Whatever is causing more damage to the lower esophageal sphincter, you want to avoid that. For this, patient should not be obese. Patient should leave all these things which are damaging the lower esophageal sphincter, whether it's alcohol, smoking, spicy, fat, fried food, caffeine, citrus fruits or juices. You are also advising the patient to go to bed after 3 to 4 hours of meals. We know that people who have got good habits, like we can just quote the example of Chinese people. In China, generally they finish their dinner by 6 or 7 in the evening and they go to bed at 10 or 11 in the night. That means they want to have a gap between their meals and sleep. Simple reason. Whatever you eat, beta, that remains inside your stomach for 2 to 3 to 4 hours. So if you take the meal and then goes to sleep immediately after that or lie on the bed immediately after that, what happens? If the food is inside the stomach, the intragastric pressure will be high and this will force the stomach contents to move up. And the chances of reflux, heartburn, GERD would be more, right? So we should avoid eating just before sleep. हालांकि हम लोगों की बात अलग है, हमें तो खाना खाने के बाद नींद आती है. So we tend to eat just before sleep. Also, we ask these patients to keep their head end elevated, right? If all these things does not help, then we can give a wonder drug, proton pump inhibitor. All acid related conditions, PPIs, block the acid secretion. If acid is reduced, then even if there is reflux, it is not the acid which is going to cause any damage. So we try to control with that. If by chance the patient does not respond to these treatments, then we do the investigations to diagnose this GERD. Till now, we have not done any investigation. But if the patient does not respond to lifestyle modification and PPIs, then we want to see where is the problem, what is the problem. And first investigation we can do in a patient presenting with heartburn or epigastric pain. Look at me on the screen. First investigation to be done in a patient presenting with heartburn or epigastric pain is a upper GI endoscopy. You pass the endoscope. If you see a pathology in the lower esophagus, suppose the lower esophagus is red, hot, inflamed, it can be because of GERD. So you do further investigations to confirm that this is GERD. Endoscopy in GERD may show red hot lower esophageal mucosa. On endoscopy, even if you see the reflux coming towards the endoscope from the stomach, this does not mean that patient is suffering from GERD, because the normal individuals can also have normal refluxes for 3 to 4% of times in 24 hours. That means if you are to label this as disease, you have to demonstrate that the frequency of these refluxes is more than 3 to 4% of times in 24 hours. For that, we have to do a study for 24 hours in the esophagus. We keep a pH monitor in the esophagus for 24 hours, which can give us the recordings for 24 hours. And if on those tracings we find that pH inside the esophagus is dropping for more than 3 to 4% of times in 24 hours, then we label that yes, this is a disease. For example, this image what we are going to see here. Now, if you look at this particular picture, Vita, in this particular image, this is a 24-hour ambulatory pH monitoring. Herein, we put a pH monitor in the esophagus and we do a recording for complete 24 hours. The study started at 10 o'clock in the morning and here it is shown up to 8 o'clock next day. The normal pH inside the esophagus is between 5 to 7. Normal pH in the stomach is between 1.5 to 2, or you can say 1.5 to 3 or 2 to 3. Strongly acid inside the stomach. Okay. So if you do a study in a GERD patient, suppose this is the basic borderline. 5 to 7 is normal. This is normal. But if the pH drops below 4, then we start calling it as pathological. And to label GERD, this drop in pH below 4 should occur for more than 3 to 4% of times in 24 hours. So here when you are doing the study, Vita, right from 10 o'clock to 6, 7 o'clock in the evening, you see that pH is above 4 only. But maybe he might have taken some spicy food at 5 or 6 o'clock and suddenly you see a drop in pH here. Now when he has gone to sleep at bedtime, obviously the chances of reflux will be more if the head is in a down position. If somebody is standing versus sitting versus lying, the chances of refluxes will be more in the lying down position, right? So when he has gone to sleep, Beta, see for how many times the pH is dropping below 4. Now this frequency of drop in 4 pH is more than 4 times in 24 hours, then we label that yes, this person is suffering from disease. And 4th June 2022, there was a single line, a simple question, gold standard investigation for GERD. Answer was 24-hour ambulatory pH monitoring. Okay, I hope you have got the concept. What we have done in a GERD patient till now, first we advised him lifestyle modification and gave PPIs. If he is not responding to this treatment or he is not taking this treatment, then we are doing investigations. First investigation is upper GI endoscopy. But upper GI endoscopy cannot label GRD. To label this GRD, we have to have a 24-hour study. And that can be a 24-hour ambulatory pH monitoring. Right? If the drop in pH below 4 for more than 4% of times in 24 hours, then yes, it is GRD. You have already given medicines, they are not working. Now, if you have proven it to be GRD, you can do surgery. And in surgery, beta, we can do that fundoplication. We can just wrap the fundus of the stomach around the lower esophagus and prevent the reflux. Right, beta? I hope you have got the concept nicely. चलिए आगे बढ़ते हैं. Let's see what all is written in the workbook. Okay. So, gastroesophageal reflux disease, beta. There are various protective factors which prevent reflux. हम आम लोगों में reflux क्यों नहीं होता? It is mainly because of the integrity of lower esophageal sphincter. Good gastric emptying. अगर स्टमक टाइम पे खाली होता रहेगा तो स्टमक के अंदर का प्रेशर कम रहेगा, लोअर इसोफेजियल स्फिंक्टर के डैमेज होने के चांसेस कम रहेंगे. If the stomach is able to empty nicely, the intragastric pressure would be low and the chances of damage to lower esophageal sphincter will be low. Good esophageal peristalsis. If the peristaltic movements are nice in the esophagus, then also they will not allow the gastric acid to move up. Despite saying this, despite all this, we all have this transient lower esophageal sphincter relaxations. Transient lower esophageal sphincter relaxation can occur for 3 to 4% of times in 24 hours in normal individuals. This will be most commonly seen in head low position. That means generally either it's a sitting position, standing position or a supine position. So supine position, the chances of refluxes would be high. Now why GRD occurs? RF is risk factor. GRD होता क्यों है? जब जब lower esophageal sphincter बर्बाद होगा, whenever the LES will be damaged, there will be chances of reflux. Most important is smoking, alcohol, chai, coffee, hot spicy food. You can write hot liquids also. Obesity, progesterone, calcium channel blockers and nitrates. These were the drugs which we were using in the treatment of eclasia cardia. Eclasia and GRD are exactly the opposite conditions. Eclasia में there is a traffic jam of the lower esophageal sphincter. GRD में there is relaxation of the lower esophageal sphincter. Right? Okay. Now, if the patient damages the lower esophageal sphincter, there will be reflux of acid into the thorax, which will lead to retrosternal pain or discomfort, which we call as heartburn. Dil jalta hai. As a doctor, in February 23, if somebody comes to you with heartburn, अगर कोई पेशेंट 25 साल का लड़का लड़की आपके पास आता है और बोलता है दिल जलता है, तो first you have to rule out the non-medical causes, something related to X and Y, ex-boyfriend, ex-girlfriend or something like that, right? But yes, we are talking about the medical story here. Apart from this heartburn beta, the patient may have epigastric pain and regurgitation. How you have to approach? This is the protocol what we use in all the acid related conditions. All the acid related conditions beta. We will be discussing the same approach when we talk about gastritis and peptic ulcers. Same approach. ठीक है, ध्यान रखना बेटा. If the patient is having retrosternal discomfort or epigastric pain, most likely the story is related to acid. So we have to focus on controlling the acid secretion in this patient. Lifestyle modification. This is the first thing you will be doing. When the MCQs will be asked, what is the next step? What is the next step? What is the next step? So the first thing in a patient presenting with epigastric pain or any acid related issue, try to modify the lifestyle of the person. Ask him to reduce the stress. Itna nahi padna hai, right? Do not overexhaust yourself. Otherwise the acid inside the stomach will increase. Stop smoking, stop alcohol, stop chai, coffee, hot, spicy food. If you are obese, reduce the weight. Do not sleep for 3 to 4 hours after meals. Elevate the head end of the bed by 5 to 8 inches. Only problem is this treatment is expensive and patients can't afford this treatment. If they can't afford this treatment, they'll keep on coming to you with symptoms. So then, if this fails, you have to give acid stoppers, proton pump inhibitors. This is the treatment of choice for GRD. Treatment of choice for GRD. Proton pump inhibitors. Proton pump inhibitors. By reducing the acid in the stomach, even if the patient is having reflux, if it is not acid, it will not cause damage in the esophagus. If medicines also fail, then we have to see where is the problem. Because epigastric pain may be due to GRD, may be due to gastritis, may be due to gastric ulcer, may be due to duodenal ulcer. So when you have to see where is the problem, I repeat beta, if the medicines are not working and the patient is continuously coming to you with some or the other problem, then we should know beta that epigastric pain story may be related to either a problem in the lower esophagus or a problem inside the stomach or a problem inside the duodenum. We don't know, so to see where is the problem, we will do a endoscopy. First investigation will be upper GI endoscopy. Upper GI endoscopy. Now beta, this is also referred to as investigation of choice in GRD. Investigation of choice. But this is not gold standard investigation. It is the investigation of choice. It is the first investigation. When you are doing the endoscopy beta, look here on the screen. Now suppose you are doing the endoscopy here and you find something in the lower esophagus. Then you start thinking of GRD story. So your next step will be 24-hour ambulatory pH monitoring. But suppose I say that esophagus was normal and you don't see anything in the esophagus. You move further beta and now you have a look into the stomach. In the stomach, if you find any ulcer, then gastric ulcers can even become malignant. And gastric ulcers and duodenal ulcers, the most common reason is Helicobacter pylori. This is a bacteria and this bacteria lives in this part of the stomach. This is the pre-pyloric region. So beta G, what we are supposed to do, if you find a problem inside the stomach, then you have to take a biopsy, and this biopsy should be taken from this part of the stomach, that is the pre-pyloric or the antrum. Why biopsy from here? Because to rule out Helicobacter pylori. Also beta G, if there is an ulcer inside the stomach, since it has got very high chances of becoming malignant, so you also take a biopsy from the ulcer. Right? I repeat, a patient came to you with epigastric pain. You have advised lifestyle modification PPIs. They are not working. Patient is not getting relief. Patient is continuously coming to you. Now you want to identify where is the problem. For that you are doing a endoscopy. If on endoscopy you find a problem in the lower esophagus, then you have to do a 24-hour ambulatory pH monitoring for GRD. If you don't find anything in the lower esophagus, it is normal. Then if you find something inside the stomach, maybe ulcer inside the stomach, then you have to take biopsy from two places. One from the stomach ulcer to rule out cancer another from the prepyloric or antral region to confirm Helicobacter pylori. Okay, beta. If suppose I say that you are doing the endoscopy, the lower esophagus is also normal and the stomach is also normal. Now, when you are doing the endoscopy, now you take this endoscope towards the duodenum. And if you find something in the duodenum, then duodenal ulcers usually do not become cancer. So there is no point in taking a biopsy from a duodenal ulcer. But the reason for duodenal ulcer, most often it is the Helicobacter pylori. So if there is an ulcer here, we should take a biopsy from the prepyloric or antrum to rule out Helicobacter pylori. That is our ideal approach. I repeat, beta, when you are doing the endoscopy in an epigastric pain patient, lower esophagus, stomach, duodenum. If there is a problem in the lower esophagus, do a 24-hour ambulatory pH monitoring. If there is an ulcer inside the stomach, take a biopsy from the ulcer to rule out cancer and take a biopsy from prepyloric antrum to rule out H. pylori. If there is an ulcer in the duodenum, take a biopsy from the prepyloric or antrum to rule out H. pylori. If on investigations of this H. pylori, this comes out to be positive, then you have to give antibiotics. This is bacteria. We have to give a eradication therapy where there is a combination of 2 antibiotics and 1 proton pump inhibitor. That is how we eradicate this bacteria. Okay? Right, beta. So, you have done the endoscopy, and now, depending on what you find, if you find something in the lower esophagus, then you go ahead with 24-hour ambulatory pH monitoring. And if on this ambulatory pH monitoring, you find that there is drop in pH below 4 for more than 4% of times in 24 hours, then we label it as GRD. And this is called as de Meester score, Johnson de Meester score. This is considered as gold standard investigation for GRD. Gold standard investigation for GRD. This was the question on 4th of June. Right? Gold standard investigation for GRD. It is 24-hour ambulatory pH monitoring. If you make the diagnosis of GRD, you have already done the medical treatment that was not helping, then only you did this investigation. So now you have to do surgical treatment. And surgical treatment for GRD is fundoplication. Fundoplication. Generally, we are doing a Nissen's fundoplication. Nissen's fundoplication. We just wrap the fundus of the stomach around the lower esophagus. We can also call it as floppy Nissen's fundoplication. That means floppy means loose. Floppy Nissen's, loose. We should not make it too tight. Otherwise, it will create a traffic jam and patient will have dysphagia. Right? Okay, beta. If this is something which we are going to see at all the other places, beta G, if you find a problem inside the stomach, ulcer, you have to take a biopsy from 2 areas, one the ulcer and another the prepyloric region. Why ulcer? To rule out cancer, and why prepyloric? For H. pylori. And if you find something in the duodenum, then you just take a biopsy from the prepyloric region to rule out H. pylori. We are not taking a biopsy from the duodenal ulcer because that hardly ever becomes malignant. Right, beta? चलिए. If we take a look at the complications of GRD, क्या क्या हो सकता है? तो most common complication, what we saw, most common is esophagitis. अच्छा बेटा एक चीज और बताओ, इन जीआरडी which part of the esophagus is getting affected most? I repeat my question. If suppose I say this is the upper esophagus, this is the middle esophagus, and this is the lower esophagus. So which part is getting affected most? Very good. Acid is damaging the lower esophagus. So whatever esophagitis or whatever stricture or Barrett's or cancer will occur, that will be in the lower esophagus. अच्छा, eclasia cardia में there was a traffic jam of the lower esophagus. The esophagitis and cancer was taking place in the middle esophagus, right? But in GRD, there's a problem in the lower esophagus and the changes are also seen in the lower esophagus. This esophagitis is seen in the lower esophagus. This can cause stricture and shortening of esophagus. Barrett's esophagus can occur. And sliding hiatus hernia can occur. Sliding hiatus hernia can occur. These can be the complications of GRD. Right? Okay, beta. What is Barrett's, beta? We discussed about. लिख लिया beta? I hope you have not missed out. Okay. Right, Bitu. Now let's see what is Barrett's. Barrett's is basically intestinal columnar metaplasia of squamous mucosa of lower esophagus. Barrett's is intestinal columnar metaplasia of squamous mucosa of lower esophagus. And the hallmark of Barrett's, beta, goblet cells. म्यूकस चाहिए ना बैरियर के लिए, तो म्यूकस कौन बनाता है? गोबलेट सेल. What happens to squamocolumnar junction in Barrett's? Look here, beta. Normally, if I say that this is the esophagus, and if I say the pinky thing is the stomach, this is the normal story. But in Barrett's, what is happening, beta? This part of the esophagus, that means the lower esophagus, this part is getting columnar. अभी ध्यान से देखना बेटा, अभी in normal person the squamo-columnar junction is here. But if this becomes columnar, the squamo-columnar junction will move upwards. That means in case of Barrett's, when there is columnar metaplasia of the squamous mucosa of the lower esophagus, then the squamo-columnar junction move upwards, right? Okay, ji. So squamo-columnar junction move upwards. And since now the chances of cancer are high in this part. अच्छा बेटा ये बताओ, ये पिंकी एरिया में कौन सा कैंसर होता है जहाँ पे कॉलमनर लाइनिंग होती है? What cancer develop in this pink area where there is columnar lining? Adenocarcinoma. Normally in the esophagus there is squamous lining. Normally there is squamous cell carcinoma. Most common cancer in the esophagus is squamous cell carcinoma. But in GRD patients who develop Barrett's esophagus, where there is columnar metaplasia, then cancer in this area will be adenocarcinoma, right? So in a GRD patient, the type of cancer seen in the esophagus will be adenocarcinoma, right? In the treatment of Barrett's, beta, we want to destroy this columnar mucosa, so we can do a endoscopic laser ablation or maybe photocoagulation of the columnar mucosa. Needless to say, beta, that we will be giving aggressive PPIs also. Proton pump inhibitors will also be given. We just destroy this columnar mucosa in Barrett's. Right. Another complication of GRD was hiatus hernia. Now, in these images, suppose I say, beta, this is something normal. Some part of the esophagus, that is approximately 1 to 2 centimeter of the esophagus, lie beneath the diaphragm. Abdomen में होता है बेटा. ये 1 to 2 centimeter esophagus is in the abdomen. Majority of the esophagus is in the thorax only, but a very small amount of esophagus is in the abdomen. And this is suppose the stomach here. So here we can see, beta, the stomach is lying inside the abdomen only. This is the diaphragm. This is the normal story. But suppose we are saying something in GRD patient. That means there is a reflux of acid taking place. Now, because of this reflux, what will happen, beta? This part of the stomach will go into the thorax. So, if I use a pink color for the stomach, and if the stomach goes into the thorax like this, that means the stomach is actually sliding up, sliding into the thorax. This is called as a sliding hiatus hernia. This should be differentiated from another type of hiatus hernia which is not related to GRD. Sometimes what can happen, beta, there may be a weakness in the diaphragm here. Normally, what you are seeing here, beta, suppose this is the diaphragm here. And by chance, if there is a weakness in the diaphragm, then because of this weakness, the stomach can go into the thorax from this weakness. Now, this is something which is not seen in GRD. Right? This is not seen in GRD. Okay? It is the fundus of the stomach. The gastroesophageal junction is here. The gastroesophageal junction is here. This is the gastroesophageal junction. But here what is happening? The stomach is actually pushing the esophagus. It is sliding into the thorax. So in a sliding variety, the gastroesophageal junction goes into the thorax. But in a paraesophageal variety, gastroesophageal junction remains in the abdomen. It is the fundus of the stomach which is going into the thorax because of a weakness in the diaphragm. So that is the basic difference between a sliding hiatus hernia and a paraesophageal hiatus hernia. This is the paraesophageal hiatus hernia. Okay. If we try to take a look, the difference between sliding and paraesophageal, beta. This is a table what we have made. So now if we just focus on this table, beta. Right. Now here, this is the sliding hiatus hernia. And here it is the paraesophageal hiatus hernia. Paraesophageal hiatus hernia, the other name is rolling or giant hiatus hernia. Rolling or giant hiatus hernia. Right? This has been asked as a question in the exam, beta. What is a giant hiatus hernia? And the answer was paraesophageal hiatus hernia. Okay. Now if we take a look at the differentiating points, beta, what happens to G junction? What is the incidence? Which is associated with reflux? Which has more chances of complications? How they present? What is the first investigation? And what is the treatment? Okay. So here in beta, now tell me What happens to G junction in sliding hiatus hernia? This, I suppose I'm drawing this. This is the G junction. And here this is the G junction. So you can very well see beta, in a sliding hiatus hernia, the gastroesophageal junction goes into the thorax, but in paraesophageal it remains within the abdomen, right? Which is more common? Sliding is more common. Reflux association GRD is seen in sliding, not in paraesophageal. The chances of risk and complication are less in sliding, but they are more in paraesophageal. There are more chances of ischemia and strangulation in paraesophageal. We can very well understand better that if stomach has gone into the thorax, the patient can have chest pain. The stomach may be pressing on the lungs, so there will be difficulty in breathing, dyspnea. First investigation, what we are doing is a chest X-ray, right? But the investigation of choice is a CECT, where we give the oral contrast as well, oral contrast. Why so, beta? This is the chest X-ray. Look at the screen, beta. Normally, this stomach shadow is seen here in a normal X-ray. The stomach air fluid level is seen here beneath the left dome of the diaphragm. But if the stomach has gone up, you will see the stomach shadow in the thorax. So by looking at this X-ray, we can say that yes, the stomach is in the thorax. So this is a hiatus hernia. But in this X-ray, we are not able to see where is the G junction, whether the G junction has gone into the thorax or it is still in the abdomen. For knowing that, we have to give the contrast. And now when we are giving the contrast, here, if you are able to see the gastroesophageal junction in the thorax, like suppose this is the diaphragm area, beta. If you are seeing the G junction in the thorax, then you will label that yes, this is a sliding hiatus hernia, right? So the best investigation or the investigation of choice would be a CECT with oral contrast. And the treatment of all hernias is one. जो अपना घर छोड़ के चला गया है, उसके कान पकड़े जाएं, उसको वापस घर में बुलाया जाए और ऐसा ताला लगाया जाए कि दोबारा बाहर जाने की गलती ना करे. The basic treatment of all the hernias in the body. Concept is one. Hernia is when somebody has moved out of his house. You have to just pull that back into the house and then create a barrier so that it does not go out again. Here what we have to do, we have to bring the stomach back into the abdomen and then wrap the fundus of the stomach around the lower esophagus so that the stomach cannot go up into the thorax again. That means we are doing a fundoplication, right? Fundoplication, right, beta? So this is all what we have studied related to GRD, right? Now what we'll do, beta, because I've already exceeded the time limit what I gave. I'm really sorry once again for this, beta. That was just because of some emergency which arrived suddenly at around 4 o'clock in the afternoon, for which we had to delay the class almost up to 6:35 p.m. But we are able to make up at least for that half an hour loss, and we are done with the majority of the thorax stories in adult surgical problems. We talked about dysphagia, we talked about GRD, we talked about complications of GRD, whether it was esophagitis or stricture or shortening or Barrett's esophagus or a hiatus hernia, right? Now, whatever doubts you would be having, beta, because it is too late and I do not want you to keep waiting. However, if you have got any doubts, beta, please do write to me on my WhatsApp. I'm just sharing my WhatsApp number here. Please do write to me on 9999683985, and by tomorrow morning, 9 or 9:30, I would be responding to all your queries, beta. by 9:30 a.m. tomorrow, I'll be able to complete all your queries and doubts. Right? I do not want to keep you waiting at this point of time. Thank you very much for your patience, beta. Just keep that one thing inside you, that you are here for a purpose. This is a war which we are fighting out. एक जंग है जो हम लड़ रहे हैं. And this war requires a lot of things inside us. It is not only the academic knowledge or the concepts we are gaining, but it is also a strict discipline which we have to maintain throughout during this journey. We should be knowing that yes, this is the time when I have to revise, this is the time when I have to attend the class, this is how I have to write the examples and everything. Always be honest to yourself. Always keep on doing good things about others. Never say anything bad about anyone. Always keep motivating others. Keep respecting your parents. Keep respecting your colleagues, your juniors, your seniors. God is watching you, beta, and He'll definitely help you. You will come out with flying colors if you keep this consistency going. Nobody on this earth has the power to defeat you. Good night. Take care. Bye-bye. Thank you. God bless.